So, ma'am, we can start now. Thank you.
Yes, ma'am. Okay, thank you. Uh, Good afternoon and a very warm welcome to the office bearers of IIP Palghar branch and also the speakers and other participants of the CME. Today we assembled here for the monthly CME organized by IIP Palghar branch. We have excellent speakers on various topics across various subspecialties. So without any further ado, I will start today's session. I welcome our first speaker, Dr. Nilesh Palwankar, sir, senior pediatrician from Abhinav Hospital, Virar, and sir is also in charge of NICU of VVC MC Virar. So, sir will be speaking about an interesting case discussion of hypernatremia in a newborn.
Good afternoon.
Sir, please take over.
Okay, I'll just share my screen.
Yes, sir.
Just give me a minute. Am I audible to all? All participants, am I audible?
Yes, sir.
Yes,
Okay.
sir. Yes, sir.
Good afternoon, everyone. First, I would like to thank Palghar Academy of Pediatrics for giving me this opportunity for presenting today's topic, hypernatremia in newborn. As summer is getting hotter, I suggest all of us to stay well hydrated all the time. With this note, I would like to start my today's presentation, hypernatremia in newborn. So my today's presentation has four contents. Part 1 is about case report, which will take around 2 to 3 minutes. Part 2, basic science, which take around 3 to 5 minutes. Part 3, today's main topic of discussion, hypernatremia in newborn. Part 4, calculation and methods to correct hypernatremia, which may take 5 to 7 minutes. As if I have to extend my time on presentation, everyone has to bear with me because the topic is lengthy, bit complex, very important practically, and every one of us should know the calculation of fluid when we correct hypernatremic dehydration. So let us go through the case report. So let's go through case report. 17 days old female child was brought by relatives with complaint of weight loss, refusal to feed, and excessive sleepiness. Obstetric history: mother was primigravida. She had a full-term normal delivery. Baby weight was 3.6 kg at birth. Baby cried immediately after birth. Mother was discharged on day 3 on exclusively breastfeeding. When we examined the baby in OPD, the temperature was 97 degrees Fahrenheit, heart rate was 106, respiration was 30, saturation on air was 94, and on OPD, the baby's weight was 2.6 kg. So there was around loss of 1000 gram. There was obvious sign of dehydration and the baby's color was not good. CNS, baby was lethargic, hypotonic, and there was some spontaneous eye opening and baby was easily arousable. Rest of the systemic examination was within normal limit. Initial treatment was normal saline bolus 20 ml kg to correct the dehydration, and then we started with maintenance fluid, that is ISOP. As there was no complaining of vomiting, we started with tube feeds and supported the child with antibiotics. Initial investigation, what the abnormal reports: platelets were to our surprise 29,000. Creatinine was high, which was bit obvious, 1.84, but for us serum sodium 178 was quite high. In further management, we did correction of the fluid deficit in next 48 to 72 hours and sodium gradually improved. Now I will just go through the investigation chart. So on day of admission, that is 20th March, the platelets were 29,000, creatinine was 1.84 and sodium was quite high, that is 178.3. We were little skeptical about the platelet count, so we did the platelet count again in the evening and it was still low, 20,400. On 21st, after fluid correction, we did repeat blood test which showed again low platelet of 26,000. There was bit improvement in the creatinine 1.5 and expected fall in the sodium 164, although it was little more, but that was it. We did again blood testing on 22nd. The platelet was still lower on the side, but there was significant improvement in the serum sodium. Again, it has fallen down by 10, that is 154. On 24th and 26th of March, the serum sodium stayed normal and the creatinine came down to 0.7. CSF was normal. There was no growth in the blood sample and the CSF sample. So our diagnosis was hypernatremic dehydration with inadequate feeding. So now let's move to the part 2, basic science. So what is osmolality? Osmolality is nothing but the number of solutes present in 1 kg of solvent. So when we talk about the plasma osmolality, we are indirectly talking about the solutes which are present in the 1 kg of plasma. So what are the main solutes which are present in the plasma? They are sodium, sugar and urea. So what is the formula to calculate plasma osmolality? The formula is twice the sodium plus glucose divided by 18 plus blood urea nitrogen divided by 2.8. As everyone of knows, glucose and blood urea nitrogen we calculate in milligram per deciliter, but sodium we calculate milliequivalents per liter. So divide by 18 and divide by 2.8. These are the conversion factor to change milligram per deciliter to milliequivalents per liter. So I will repeat the formula again. 2 into sodium plus glucose divided by 18 plus blood urea nitrogen divided by 2.8. So what is the normal value? Everybody of us knows from college days it is 285 to 295. Anything less than 285 is hypo. Anything more than 295 is hyper. So let us go to the next concept, osmosis. What is osmosis? Osmosis refers to a movement of water from a region of low solute concentration to one of high solute concentration across a semi-permeable membrane. So this is a semi-permeable membrane. The membrane is permeable to water but not to solute. This is number of solutes in compartment 1, which are bit more, and these are the solutes in the compartment 2. So then you can see the movement of water from low concentration area to higher concentration area. So this movement of water is called osmosis and it is called as a osmotic gradient. This is high solute concentration, this is low solute concentration, and there is a movement of water across the semi-permeable membrane. Now everyone of knows that water in the body is divided into two compartments. One is intracellular compartment and other is extracellular compartment. Now extracellular compartment has major portion that is called as plasma. So the main solute in the plasma is sodium and the main solute in the intracellular fluid is potassium. Why it is important? I will tell you in the next slide. So now how the body tonicity is regulated. Tonicity is nothing but the effective osmolality. Although tonicity and osmolality are comparable, there is a slight difference between them. Tonicity refers to the osmotic pressure across two solutions separated by a semi-permeable membrane, but this membrane is not allowing to cross the solutes freely. Hence, body tonicity includes both intracellular fluid and extracellular fluid because the solutes in the extracellular fluid are different and solutes in the intracellular fluid are different. Sodium and glucose are the primary solutes to maintain the extracellular fluid tonicity and osmolality. In contrast, because blood urea is permeable to membranes and contributes osmolality, but not body tonicity. That difference is there between the osmolality and tonicity. Because urea can pass through the semi-permeable membrane like water, it will not contribute to the tonicity. So if there is an increase in blood urea nitrogen, tonicity will be the same. But yes, it will increase the osmolality. So what is the okay, potassium is the only contributing factor for the intracellular fluid tonicity, which is way beyond our discussion. Intracellular tonicity. Now the formula of tonicity is simple. Whatever formula we have seen before, you have to just deduct blood urea nitrogen. So formula will be 2 into sodium plus glucose divided by 18. Suppose now the serum sodium is around 150. So 150 into 2 is 300. We will take sugar 180. So 180 divided by 18. So it is 10. So if serum sodium is 240, serum sodium is 140 and your sugar is 180. So your tonicity will be how much? 280 plus 10. So that is 290 will be my the tonicity. The calculation is very simple if you know the conversion factor. Hence, the hypertonic plasma causes water to move towards the intracellular fluid compartment, resulting in cellular edema. And hypernatremia causes the shift of fluid from intracellular compartment to the extracellular compartment, leading to cellular shrinkage. Now, let us move on today's main topic, which is bit lengthy, which may take around 30 minutes if we want to understand the topic thoroughly without missing anything. So today's main topic is hypernatremia in newborn. So let's all of us try to concentrate on our screen. What is the incidence? The precise incidence is very difficult to understand because many babies are discharged. So it is difficult to ascertain the incidence, but it varies from 1% to 1.8%. In some studies, it has reached to 5.6%. What are the main risk factors? The main risk factor for hypernatremia and term newborns are basically related to early discharge from the hospital, especially in cases of normal delivery with ineffective lactation support or insufficient milk production leading to a lactation failure. So if there is a normal delivery, if primigravida mother is there, and if we don't put proper attention towards lactation technique and milk production, the baby may land into a problem. In preterm babies, the incidence is high as 40% because there is insufficient fluid intake, excessive fluid loss because of the very preterm skin, or excessive sodium intake during the fluid administration. The mortality and morbidity are related to hypernatremia itself, but inappropriate fluid management. It means if we are giving faster fluid, if we are giving hypoosmolar fluid, then there can be problem in outcome. How we classify the hypernatremia? Everyone of knows normal serum sodium value 135 to 145 milliequivalents per liter. Anything above will be classified as hypernatremia, Mild 146 to 149 where you don't have to worry much. Moderate 150 to 169, severe 170 to 180, and anything above 180 will be considered extreme hypernatremia. You can get serum sodium up to 190, 195. I never heard about 200. Now different books are having different classifications. So I have taken from where I felt it is appropriate. Now, what is the pathophysiology of hypernatremia? Why we have to worry about hypernatremia? In normal state, no net movement of water is in either direction, either intracellular or extracellular. But if there is increase in the amount of sodium in the extracellular fluid, what this increased amount of sodium will do? It will create hypertonicity in the extracellular fluid. Okay? And what we just learned, in hypertonic state, there will be net movement of water from intracellular fluid to extracellular fluid. Why? Now because there is a osmotic gradient. This movement of the fluid will continue till there is a balance across the both side of the cell membrane. This leads to decrease in the ICF volume. Now, if water is taken out from the intracellular fluid, the volume is going to decrease. Now, this decrease will lead to cell shrink and distortion of the shape. Now, if the sodium keeps increases further or it is unrecognized over several days, what will happen? Body will start having their corrective measure. The cell starts regulating their intracellular volume by producing intrinsically small solutes. They are called osmolyte. So now, if serum sodium is higher for a longer time or if it is not corrected, now the body develops their own mechanism because they can't allow the water to go out of their cell, and then cell hypofunction cannot be allowed. So then what body does? It start create intrinsically solutes which are called as osmolytes. This adaptation limits water egression from the brain cells, maintains an average brain cell volume. If there are no osmolytes, then the brain will shrink early and the complications will occur very much early. So this itself is a protective mechanism when we talk about the brain. But this cerebral adaptive mechanism may not be sufficient when in acute hypernatremia. Suppose your sodium level goes very high within few hours, definitely this adaptive mechanism is not going to come into the picture and the brain cells will get distorted and the structural changes in the brain will happen. Now, what happens if cell shrinkage is there? It will cause separation of the brain from the meningeal layers, and this eventually leads to the rupture of bridging veins with resultant intracerebral hemorrhage, venous sinus thrombosis, and infarction. So, if there is a rapid sodium in the brain size will go down and it will separate itself from the meninges, leading to bleeding. On the same time, rapid correction of hypernatremia return the cell volume of all body except in the brain. So whenever there is a hypernatremia, all cells are going to lose their volume in some way or the other. But when we do rapid hydration, there is a problem in the brain cells. That is why we will see in later slide. In the brain, rapid sodium level correction result in cerebral edema because the osmolytes which are present, they are not metabolized. Because they don't get time to get metabolized, they persist. And if there is a rapid sodium correction and the water goes inside the cell, it leads to the cerebral edema. Rapid fluid administration or administration of large amount of hypotonic fluid. So we have to understand, you have to go slow and you have to go with proper tonicity depending on the serum sodium level to prevent the cerebral edema. Rapid fluid administration or administration of large amount of hypotonic fluid can cause significant change in extracellular fluid osmolality and shift in water from extracellular to intracellular fluid. Eventually, it will lead to cerebral edema, and sometimes it may lead to possible irreversible cell damage. So we have to see to it that fluid administration has to be in a proper way if there is moderate to severe to extreme hypernatremia. So if you see this figure, it will tell you everything in nutshell. If you look at figure A, there are different compartments: interstitial fluid, intracellular fluid, extracellular fluid, and plasma. So if you see the four arrows, they are in harmony. But when the plasma becomes hypertonic, the water will move from inside the cell to plasma. If you move towards the right, it will go to the cell distortion, cerebral cell shrink, and then bleeding inside the brain and seizures. On the contrary, if you rapidly infuse fluid or if you give hypotonic solution, what will happen? Plasma become hypotonic. Now the water will rapidly move from the plasma to the cells. Now cell doesn't get time to metabolite the osmolytes, which will lead to cell swelling, which will lead to cerebral edema, which will lead to encephalopathy and central pontine myelinosis. So fluid doesn't causes the cell edema because we don't give time to the brain cell to metabolite the osmolytes. That's why there is a cerebral edema. Don't have confusion ki water is causing cerebral edema. No, because we are not giving brain enough time to metabolite whatever osmolytes they have created as a protective mechanism. So many of times we feel, अरे मी हायपोटोनिक सलाईन दिलं ना म्हणून बाळाला सेरिब्रल एडिमा झाला नाही, because we haven't given enough time to the brain cell to metabolite the osmolytes. So that is very important. We have to give time to them. Now the time will depend on the severity. If lesser the hypernatremia, lesser the time. More is the hypernatremia, more time we have to give. And there is a specific calculation which I will tell you in the next slides. What is the etiology? Now everybody knows about the etiology. I'll just go through quickly. Increased water loss, especially in diabetes insipidus, vomiting, diarrhea, transepidermal loss, especially in preterm babies. That's why we keep them in incubator. Osmotic diuresis in hyperglycemia, diuretic phase of respiratory distress syndrome. These are the causes for increased water loss. Now, what are the causes of hypertonic sodium gain? Sometimes mother make concentrated infant formula and they kept feeding till the child becomes symptomatic. Sodium bicarbonate infusion during resuscitation. Rarely, some mothers they have high sodium content in their breast milk. That is also reason for hypertonic sodium gain. Inadequate intake is very obvious. Poor breastfeeding technique or inadequate milk secretion. In tropical countries during summer, hypernatremic dehydration is common in neonates. So if you see hypernatremic dehydration, it is common in summer and it is very common in countries like India. Obviously, a faster discharge of mother, poor breastfeeding technique, and inadequate milk secretion and high content of breast milk also contributes. But in especially summer, all these things get aggravated. What are the clinical features? Everyone of knows the clinical features, but they are variable and they may appear very late. Why they appear very late? Because brain is trying to protect the change in the volume by creating the osmolytes. Patients are irritable, restless, weak, lethargic. Some of them they have high pitch cry, hypercapnia. Hypernatremia may cause fever also, but there may be other pathology underlying. What we feel ki hypernatremia is always associated with dehydration. No, if it is a rapid hypernatremia, even without dehydration, it causes central nervous system symptoms. But those symptoms will be parallel, one to the degree of sodium elevation and two the speed with which it has increased. So it is not necessary that every hypernatremic child will be dehydrated. So child is not dehydrated, so there cannot be hypernatremia. It is not like that. So that we have to consider. Hypernatremia is also associated with hyperglycemia. If sugar is 200, don't worry to treat it with insulin. If low calcium is there, which is mild, don't be in a hurry to give calcium gluconate. The mechanism is unknown, but as you correct the hypernatremia, it will get corrected by itself. See, beyond the sequelae of dehydration, whenever there is a hypernatremic dehydration, every cell is going to affect. But there is no clear direct effect of hypernatremia on the other organ tissues except brain. So whenever there is a hypernatremic dehydration, the brain is at stake in both the ways. One, when there is hypernatremia. Second, when you correct the fluid. So brain is having stake during both the situation. Other organs, heart, kidney, lung, everything, they metabolite and they take the fluid in their cells very well. Brain hemorrhage is the most devastating consequence, one which can face in untreated hypernatremia. The decrease in brain size can result in tearing of intracerebral veins and bridging blood vessel as the brain moves away from the skull and the meninges. Patient may have different types of hemorrhages like subarachnoid, subdural, parenchymal hemorrhages. We think seizures and coma is common because of the hemorrhage. But rather than that, seizures are more common during correction of hypernatremia. If we don't do proper calculation, the child may land up with seizures. Neonates, especially if premature, seems especially vulnerable to hypernatremia and excessive sodium intake. There is definite association between rapid or hyperosmolar sodium bicarbonate administration and the development of intraventricular hemorrhage in neonate. So because pH is less, pH is acidotic, don't be in a hurry to give sodium bicarbonate. Think 10 times whether you have to give sodium bicarbonate. If you are writing a sodium bicarbonate prescription, you write it down properly and tell the sister that they have to be very slow. If possible, give by syringe pump, and whatever rate you told them, you see to it that the same rate is going. Because if you write 10 ml in 10 minutes and if they said 5 ml in 5 minutes, there is going to be a problem. So you have to see to it that the rate of soda bicarbonate is exactly what you have mentioned in the paper. This we can definitely avoid. This is iatrogenic. So whenever you write soda bicarb, be very, very sure. Also, there are some thrombotic complications in severe hypernatremic dehydration: stroke, dural sinus thrombosis, peripheral sinus thrombosis, and renal vein thrombosis. Investigation everyone knows, only I would like to suggest, if possible, go for osmolality in urine. Again, you can go for different electrolytes in the urine. If your serum sodium is very high, like 190, urine osmolality if it is possible. But definitely, if the history is suggesting of diabetes insipidus, like baby is dehydrated and passing large amount of urine, you can think of diabetes insipidus. And if there are CNS manifestation, then you can go with neuroimaging. Management. The principle of hypernatric management in newborn includes four things. One, identify and treat the underlying cause. Second, correcting the underlying fluid deficit. This is very, very important. Third, ensuring that there is enough free water to safely lower sodium towards normal value. See, two words are important. What? Enough free water and safely lower the serum sodium. Identifying and treating underlying cause, everybody will do. Correcting the underlying fluid deficit, we will do. But what about the enough free water, and what about the safely lower sodium level towards the normal value? So these three things are important: fluid calculation, calculation of the free water, and the duration. These three things we must know, and obviously continuing the maintenance fluid. The aim of management is to slowly normalize the serum sodium level by giving sufficient amount of free water. You have to give sufficient amount of free water, that is number one, and you have to give sufficient time also. How to calculate that, we will see later. Now, Different calculations and formulas to correct hypernatremia and neonates that are discussed in literature have different free water calculation. If you say every will book have different figures. However, the principle remains the same: prevent rapid decline in serum sodium concentration. Now, if there is a case of a hypernatremia and you are in OPD or you are in NICU, so how to go a stepwise approach? Very important. First, take detailed birth history, feeding history, postnatal history. Then you have to ascertain the sensorium, because the sensorium will only tell you what are the complications are there in brain. At the same time, cardiovascular status, because if the pulses are low, you have to give normal saline bolus, so you have to repeat a normal saline bolus. So a cardiovascular status assessment and sensorium status assessment is very important. Again, we have to give special attention regarding the urine output. If the child has not passed urine in 24 hours, and if you keep giving boluses, it is going to create a problem. So you have to take detailed history of urine output in last 12 to 24 hours. If the child is pouring lot of urine and child is dehydrated, maybe you are dealing with diabetes insipidus. But if the child has not passed urine in last 24 hours, so maybe you are dealing with a child with hypernatremia with anuria. The management will be totally different. So if the renal is shut down, the calculations are different. If kidneys are open, the calculations are different. Definitely, we have to make efforts from our side to get quick lab reports. If possible, we should have two different peripheral lines, and we must have a clear timeline for blood and urine tests to understand sodium correction. You cannot have arbitrary timeline. The more severe is the hypernatremia, more stringent should be the timeline. And definitely, last but not the least, if there is a child of hypernatremia, you must keep 3% saline with you. अरे hypernatremia मग कशाला 3% saline? Why we should have it? I will tell you in next slide. Now, very important, understanding calculation of fluids for sodium correction. I think for next 4-5 slide you try to concentrate well. So there are different type of deficit. First, we have to calculate free water deficit. Now, if you take any fluid, the water is in two form. One is bound form and another is free form. Bound form is bound by the hydrogen bonds. It is not available for exchange. Free water is not bound to the hydrogen bonds, so it is available for the exchange. So we have to calculate the amount of free water deficit given for the weight and for the type of dehydration, means type of hypernatremia. Now, what is total fluid deficit? It is very simple. What was the initial weight and what is the present weight? Suppose initial weight was 3.5. Now it is 2.5. So there is a loss of 1000 gram. The total fluid deficit is 1000 ml. So now you know what is the total fluid deficit. It is simple. Now third, solute fluid deficit. What is solute? Solute means saline. So what is the amount of fluid which is having saline? So formula is what TFD is there, you have to subtract FWD. So if you want to get the solute fluid deficit, you subtract free water deficit from total fluid deficit. I will repeat again: free water deficit, total fluid deficit, and solute fluid deficit. Now I am clearing your concept now only. For free water deficit, you have to give 5% dextrose. अरे hypernatremia है तो 5% dextrose कसं देणार? 5% dextrose only contains free water. So if you don't give 5% dextrose, how you are going to give free water? So 5% dextrose has to be given. Don't scold your resident. Are 5% drip lava. Then you will say 5% dextrose, why you are giving? but 5% dextrose is only going to give you free water. So you have to give 5% dextrose in hypernatremia, but how much? That calculation is important. And for solute fluid deficit, you have to give 0.9% saline, that is normal saline. So two fluids, for free water deficit 5% dextrose, for solute fluid deficit NS. So your two fluids are finalized. One is 5% dextrose, another is normal saline. Now, free water calculation in moderate to extreme hypernatremia for infants and newborn. To drop serum sodium level by 1 microliters per liter. आता समजा बाळाचं serum sodium is 180. Now I have to bring down to 179. How much free water I have to give? So there are definitive calculations. So please concentrate. So if my serum sodium is between 150 to 190, my free water per kg will be 4.5. How it has derived? My sodium level was 150. I want to bring it down by 1. So 150 minus 149 divided by 150 into 1000. 0.7 is 70% of water there in the body newborn. So that is 0.7. So if you put 150 minus 149 by 150 into 1000 into 0.7, it will correctly come to 4.5. So this is the amount of free water you have to give per kg. Okay. Now, if by your hard luck, if you get a child who is 190 milliequivalents, now your free water will be different. The formula is 190 by 189 by 190 into 1000 into 0.7. It will come to 3.5. So if your sodium is 150 to 190, you can safely use 4.5 ml per kg. And if your sodium is 190, suppose it is 200. So you have to use 3.5 ml per kg. So this much is the free water you have to calculate. The further calculation regarding free water we will see later. So this is, you remember, free water 4.5 ml per kg. And if it is extreme, 3.5 ml. This is standard everywhere. All books will say this only. Now, understanding calculation of fluid for sodium correction, we are taking it further. Maintenance fluid, everybody knows, depending upon the age. Insensible water loss. If baby is in the cradle, open cradle warmer, insensible water loss will be different. If it is in the incubator, insensible water loss will be different. If you are giving phototherapy, again, water loss will be different. You have to add. Now, very important, calculating duration of sodium correction. If 160 is there, what should be the time? 180 is there, what should be the time? 190 असेल तर what should be the time? So there is again a formula. What is that formula? To bring down sodium level to 145 milliequivalents per liter with rate of 0.5 milliequivalents per hour. So sir, from where this 0.5 milliequivalents per hour has come? So when we correct hypernatremia, the sodium should not fall more than 12 milliequivalents in 24 hours. So if my serum sodium is 190, next day it should be 180 or maximum 178. So what is maximum fall is allowed to me is 0.5 milliequivalents per hour. If the fall is 1 milliequivalent per hour, then it is like 24 and baby is going to land into complication. So what is the duration? The duration is present your patient's value minus desired value divided by 0.5. For example, my serum sodium is 160, my desired is 145. So 160 minus 145, 30 hours. जर माझं सिरम सोडियम 160 असेल तर मला 30 तास पाहिजे फॉर करेक्शन. ठीक आहे. The calculation will go on like this only. Now, some books they will like to talk in days. So there is formula for day also. Patient sodium minus 145. The upper is same. Lower you divide by 15. From where that 15 figure has come, I don't know. It will be around days required for correction. So if roughly, if moderate to severe hypernatremia, it will be 1 to 2 days. It will come 1.2, 1.3, 1.5, 2.1, something like that. But if it is extreme, the days will be 3 to 4 days. But I personally feel going with above formula is simple. Present sodium level, desired sodium level divided 0.5. For example, समजा 170 आहे. So 170 वजा 145 भागिले 0.5 will be how much? 7, म्हणजे around 50. So 50 hours if serum sodium is 170. If it is 180, so 180 minus 145, that is 35. 35 divided by half, so 70 hours. So like that the calculation will go on. I think everybody is with me. Yeah, so I'll go ahead. Now this is very interesting, right? This is very important to understand why we should not use 5% dextrose completely and why we should not use normal saline. So if you, the slide looks a bit complex, but it is very easy. On left side, there are different types of solution which we use every day. And on the top, there are different serum sodium levels. So we will not look into 170, 180, 190. Let us first concentrate when the serum sodium is 160. Suppose I decide I will give only 5% dextrose. What will happen? You will be giving 100% of free water. If I give 500 ml of 5% dextrose, the child will receive 500 ml of free water. Definitely cerebral edema. Now, if I think, no, I don't have anything, मला भीती वाटते, I will go with NS. So if I give NS, what will happen? The bound water is 96%. Free water is 4%. So if I give 500 ml of NS to the child, he will only receive 20 ml of free water. What change is going to make? So it is better you go to one step above. So that is half normal saline. As the name suggests, isotonicity is half and free water is half. So at least I am giving half of the water. So if we use half normal saline, yes, we are giving adequate amount of free water. So 5% dextrose alone is big no. 9% normal saline, 0.9% saline is big no. 1/5 saline, again if you see, again it is giving very big amount of free water. So that is also no. So what we are left with? We are left with half normal saline. If you are thinking to correct only with saline, then you should use half normal saline or half DNS. You cannot use 5% dextrose alone. You cannot use 1/5 saline, which we use for maintenance alone, and you cannot use normal saline alone. If you have to go with only one solution, then yes, you can think of half normal saline. So some books, like in pediatric, they like to go with half normal saline. But definitely this formula is not good when we talk about the newborns. So what are the formula for that? We'll see. Now we have to make a schedule for hypernatremic dehydration. आता baby is there for hypernatremic dehydration. We have to make a schedule. So what is the schedule? Now free water deficit, I told you the formula 4.5 ml per kg. ठीक है? Now you have to calculate this free water deficit and then you have to calculate the duration. Suppose the calculation of free water deficit is 700 ml and your duration is 70 hours. So 10 ml of free water, that means 5% dextrose you will give. You got my point? So free water deficit you have to calculate depending upon your severity of hypernatremia. For moderate the time will be different. For severe the time will be different. The extreme the time will be different. So free water deficit divided by the amount required for the correction is the rate which you have to give in free water deficit. Free water deficit is nothing but 5% dextrose. No, don't think of distilled water. It is 5% dextrose that you have to use.
Sir, sorry to interrupt. Can we have in five? Can we finish in 5 minutes? Like,
Pardon?
uh, uh,
Time.
like
Yeah, I'll
time.
be
Yes, sir.
finishing.
Yes, sir.
Yes.
Yes, sir.
See, what I am
Thank
trying
you.
to tell means that is okay, time constraint. But if hypernatremia is there, and if I just go through, and if they don't know what has happened, then there is no point. So I told in the beginning, please bear with me. It is very important topic. Some may like to listen. So just allow me few more minutes. I will try to finish. Now, solute fluid deficit is like other dehydration. Half in first 8 hours, half in next 16 hours. What you will use here? You will use here NS. And for maintenance, you use ISOP or 10% dextrose depending upon the situation. So now, if, in a nutshell, if you put hypernatremic dehydration, how you can go ahead for mild hypernatremia, maintenance fluid is enough. Duration will be around 12 to 24 hours. 10% dextrose, 5% dextrose is enough. There is no need of switch over. 24 hours blood test you can do. If it is moderate, you have to support the child with bolus. You have to calculate free water deficit, solute fluid deficit, and maintenance. So one line is free water, another line is solid fluid deficit, third line is maintenance. Duration will be around 24 to 48 hours. In second method, if you are very much confused कि बाबा हे फ्री वॉटर काय हे मला कळत नाही, you go with DNS and half DNS. The calculations we will see sometime later because there is a constraint of time. Switchover should be done with isolite P at 145. Duration 24. Every 12 hours you can do the blood test. In severe, again you have to take help of bolus, free water deficit, solute fluid deficit with maintenance. But the duration will be more, 48 to 96 hours. Again, if you don't want to go in this clumsy calculation, you have to again you can use half normal saline and DNS, but the ratio will be reversed, and then you can use isolite P once your serum sodium comes down to 95. Here you do frequent blood tests. Extreme hypernatremia is very difficult to treat. You require special solution. You require support by dialysis, and the calculations are bit complicated. I will just skip because less time is there. Practical tips. Special solution is needed when you are dealing with serum sodium of 190, 195. Calculation I am not going in detail. If you don't have special solution, what you will do? You start with normal saline, doesn't matter. And then you keep frequently checking the serum sodium level. Once it comes down to 180, you can go with your formula. If there is a fall in sodium concentration more, then according to second method, you can increase the normal saline rate. If the fall is less, then you should increase the half saline rate. Now, suppose the patient is having serum sodium of 180, okay, and after 12 hours you go, and if there is a fall of 12, means in 12 hours it should be 6, and if it is 12, don't worry, you increase the saline rate, that is 0.9, and you reduce the half saline rate. There are calculation, but time is not allowing me to tell in detail. These are actually beautiful calculation, but the moderator has asked me to wrap up. One thing you should always remember, if you are giving second bolus in hypernatremia, from second side you must give 3% normal saline, because when you give second bolus you are creating a hypoosmolar state, and child is going into cerebral edema. It can happen ki you have given first bolus, there is no improvement in the pulses, then if you are going with second bolus, from second side you must start 3% and this you don't forget. If patient get convulsion, quickly give 3% saline. What is the formula? 5 ml per kg over 5 minutes you give. There is no need to treat fever or acidosis or hyperglycemia. They will be taken care by themselves. Antibiotics only if septic skin is positive. maintain glucose level all the time because we are dealing with newborns. In clinical, if clinically baby stable, serum sodium is around 160, you can only go ahead with oral correction, and then you do repeat serum sodium. There is definitely no role of oral route if your sodium is more than 160. So if it is more than 160, 165, child is taking orally, well, I will go with oral. No, you have to start with the formula. And oral distilled water is very much contraindicated. Don't put your logic, अरे मी पाणी देतो ना, पाणी दिल्याने बाळाचं सोडियम कमी होईल, अरे child will land into enterocolitis, please. So this idea is outdated. Potassium is added once urine output is there around 1 ml per kg. No need to add separate sodium. Already we are giving NS and we are giving DNS or whatnot. To take help of a nephrologist. If serum sodium is above 180, please call your nephrologist friend. If serum sodium is around 180, now there is a fluid overload and the correction takes time. So please be ready to shift the baby for dialysis. Content of mother breast milk should be assessed whenever possible. Frequent follow-ups of the baby is necessary once you discharge the baby. Hypernatremia and lactation in term neonate. Okay, a special mention about hypernatremia associated with lactation is necessary since most of the cases are prevalent in infants born to first time mother. Our mother was first time. She had uneventful delivery and she was not discharged before 48 hours. She was discharged after 48 hours, but she was not knowing the exact technique of breastfeeding. To prevent such situation, counseling, adequate lactation support, and education to mother with limited experience in infant upbringing is essential. See, it is very, very important. It is therefore sometimes it is vital to estimate human milk sodium content in an exclusively breastfed newborn presenting with hypernatremia in addition to other laboratory investigation. It means जर तुम्हाला शक्य होत असेल तर आईच्या दुधातलं सोडियम चेक करा. आता ते कुठे करतात, कसं करतात माहित नाही, मी तरी काही केलं नव्हतं. But then you can discuss among your colleagues and go ahead if you come across a case of a newborn with hypernatremia. So there is another slide, calculation and methods, but I think moderator is not allowing me to go ahead with the time. I'll just quickly run through, just quickly, how to
Yeah,
go
sure.
ahead.
Okay.
Whatever
Okay.
you are able to understand, please understand. I would have gone into detail, but time constraint. So if there is a child, calculation method 1, I am not going to touch method 2, method 3. Please concentrate. Just give me 2 minutes. So 3 fluids I will use. One is 5% dextrose, another is normal saline, third is maintenance fluid. How I will go ahead? Birth weight is 3,600 gram. Post illness 2,800 gram. So difference is around 800 gram. My serum sodium is 180. So this is my scenario. Bolus, definitely everyone will go ahead with bolus 60 ml. Total fluid deficit is how much? 3600 मधनं 2800 गेले 800, 800 मधनं 60 गेले, किती झाले? 740. My fluid free water deficit 180 is my level. I have to take down to 145. My patient weight is 3.6 kg into 4.5. It will come around 567, approximately 560. So bolus is 60, my TFD is 740, my FW is 560. So what is my SFD? Solute fluid deficit is TFD minus FWD. So 740 मधनं 560 गेले तर किती राहिले? 180. म्हणजे मला 5% डेक्स्ट्रोज द्यायचे 560 आणि मला नॉर्मल सलाईन द्यायचं 180. जर माझं सिरम सोडियम 180 असेल तर बाळाचं वजन 3.6 आणि आता 2.8 असेल तर मेंटेनन्स इट इज व्हेरी सिंपल. वी डू इन अँड आउट 360 ml 24 hours 15 ml per hour. Now crux, correction time. So my correction time is how much? 185 minus 145. How much it is? 35. 35 divided by 0.5 is how much? 70 hours. So now everything is clear. My bolus is 60. My total fluid deficit is 740. त्यातलं 560 मला 5% डेक्स्ट्रोज द्यायचंय, 180 मला नॉर्मल सलाईन द्यायचंय. तिसरीकडून माझं आयसोपी चालू राहणार बिकॉज हा मेंटेनन्स आहे. आणि माझा वेळ किती असणार आहे? 70 तासात मला हे करायचंय. पण हे 70 तास मी दोन गोष्टींसाठी वापरणार, एक 5% डेक्स्ट्रोज साठी आणि एक मेंटेनन्स फ्लुइड साठी. सो माझं जे सोल्यूट फ्लुइड डेफिसिट आहे ते मला 24 तासात करेक्ट करायचंय. कसं? अर्ध पहिले 8 तासात आणि अर्ध दुसऱ्या 16 तासात. सगळं मी हे सगळं एका टेबलमध्ये टाकलं ना तर कसं दिसेल बघा. सो फ्री वॉटर डेफिसिट 560 ml 70 hours. ओके, हे 560 आहे, 70 आहे, सो 8 ml per hour. नाव माय सोल्यूट फ्लुइड डेफिसिट म्हणजे जे मला नॉर्मल सलाईन द्यायचे ना ते 180 ml द्यायचंय. अर्ध पहिले 8 तासात म्हणजे 12 ml प्रति तास आणि पुढचं 90 ml 16 तासात म्हणजे 6 ml. तर पहिल्याच 12 तासात, पहिल्या 8 तासात माझा रेट 12 असेल, नंतरच्या 16 तासात माझा नॉर्मल सलाईनचा रेट 6 ml असेल. तर माझा 5% डेक्स्ट्रोजचा रेट वेगळा असेल आणि माझा नॉर्मल सलाईनचा रेट पहिल्या 8 तासात आणि दुसऱ्या 16 तासात वेगळा असेल. मेंटेनन्स सेम असेल, त्याची काय फार काळजी करायची गरज नाही. सो इफ अ चाइल्ड इज देअर, then in first 8 hours what will happen? 5% dextrose 8 ml, normal saline 12 ml and isop 15 ml for first 8 hours. In next 16 hours what will happen? 5% dextrose 8 ml, normal saline 6 ml, maintenance fluid 15 ml. So I will be giving 29 ml per hour. In next 46 hours my 5% dextrose 8 ml, maintenance fluid will be 15 ml, so it will be 23 ml. So in this calculation, free water means 5% dextrose, I will be giving 560 ml in 70 hours, around 8 ml per hour. So this calculation is very accurate, but then you require high vigilance. Suppose if you have started with 5% dextrose आणि एका बाजूने नॉर्मल सलाईन आणि मेंटेनन्स फ्लुइड गेलं नाही तर काय होईल? बाळाला फक्त 5% डेक्स्ट्रोज मिळेल, म्हणजे बाळाला फक्त फ्री वॉटर मिळेल आणि बाळाला सेरिब्रल एडिमा होईल. सो इफ यू आर गोइंग विथ धिस मेथड, यू शुड बी व्हेरी क्लिअर रिगार्डिंग युअर ऑर्डर्स अँड यू शुड बी व्हेरी विजिलंट की माझं 5% डेक्स्ट्रोज व्यवस्थित चाललंय, माझं सोल्यूट फ्लुइड व्यवस्थित चाललंय आणि माझं मेंटेनन्स फ्लुइड पण व्यवस्थित चाललंय. 5 तास झाले 5% डेक्स्ट्रोज चालू आहे, दुसरा सलाईनचा पॉइंट आउट आहे, त्यातनं नॉर्मल सलाईन आणि मेंटेनन्स फ्लुइड गेलं नाही, I am going to land into problem. So there is a different method by which we did calculation, half DNS, with DNS and maintenance fluid. I am not going to go through because time constraint, everything is same, but if sometime later I will try to tell you what exactly we can go ahead. And third, what we do in pediatric, half normal saline and maintenance fluid. So bolus, total fluid, maintenance, correction time, correction fluid, maintenance fluid, all that is there, but no time. Okay, but here we are giving free water 430 ml and in previous we are giving around 350 ml. But according to me, this is very vague method and you don't have any adjustable measures if your serum sodium is going very low. So before concluding, I want to put a disclaimer. I have not included extremely low birth weight hypernatremia because the calculations are very complicated. There are no fixed protocols. These are the only guidelines. In today's presentation, I try to give possible practical approach rather than minuscule management. Differences of opinion and experience ought to be there in the management of hypernatremia. Correction in the slides are always welcome. Before signing off, I want to tell that today is World Book Day. 23rd April is celebrated all over the world as a International Book Day. And I thank all the participants for their patient listening. And I thank my digital team without which this presentation is not possible. And I would like to get queries on the digital platform and I will look them personally. And with this, I am signing off. See you soon.
Well done, Nilesh.
Thank you, Nilesh sir, for the need of the hour discussion on hypernatremia. So we We can take if there are any questions. Otherwise, we can move to the next speaker.
40.
Our next.
41.
Okay. So we will move on to our next speaker. I request Dr. Madhavi Ingle ma'am to take over. Ma'am is an assistant professor of pediatrics in PGIMS Navi Mumbai and also in charge of Thalassemia Daycare Center in Vashi. And ma'am has special interest in adolescent health, hematology, and social pediatrics. So today we will all be learning about an interesting case of pediatric hypoglycemia. I welcome ma'am onto the platform and ma'am please take over.
Ma'am, are the slides visible?
Yes, ma'am. Up the slides visible. Yes.
Okay, good afternoon, everyone. And thank you, IIP Palghar Academy, for giving us a chance to present our case. My resident Dr. Pranjal is going to present the case.
Good afternoon, everyone. This is a case of infantile hypoglycemia. A 9-month-old male child resident of Chiplun, born out of non-consanguineous marriage, first by birth order, was brought by parents with complaints of an episode of seizure with history of 2 episodes of hypoglycemic seizures in the past. Patient was apparently all right one day back when he had an episode of generalized tonic-clonic seizures with uprolling of eyes with no frothing from mouth but preserved bowel and bladder movement lasting for about 5 minutes at 7 p.m. in the night. He was taken to a tertiary care hospital at night where he was stabilized, but patient took LAMA and brought patient to the hospital in the morning. There was no history of any loose motions, vomiting, fever, cold cough, weight changes, or any history of prolonged fasting. On further inquiry, patient had history of similar episodes of convulsion at 6 and 7 months of age. At 6 months, he had an episode of convulsion at home which subsided quickly. At 7 months of age, he had another convulsion at Chiplun for which he was taken to hospital and had documented hypoglycemia. So probably the patient when he came to us was in his third episode of hypoglycemic seizure. There was no other significant past or family history. The mother was registered at Government Hospital Chiplun. She had taken proper antenatal care. All medications and sonographies were taken. 2 doses of TD were taken. No history of gestational diabetes mellitus in the mother. Child was born at term by forceps delivery. 2800 gram birth weight. There was no history of NICU stay. He was exclusively breastfed till 4 months of age and was immunized up till age. Developmentally, he was normal for age across all parameters, gross motor, fine motor, language, and social. On general examination, child was conscious, active, orally well, euthermic, vitally stable. His sugars on admission were 45, which were hypoglycemic, no pallor icterus. He had doll-like faces. Anthropometrically wise, the child was normal. His weight was 8 kg, which was within 0 to minus 2 standard deviation. Length was 72 centimeters, 0 to 2 standard deviation, and head circumference 42 centimeter, 0 to minus 2 standard deviation. In the hospital stay of about 15 days, the child did not have any repeat convulsion, but had 4 episodes of documented hypoglycemia on his regular feed. His critical samples were sent. His MRI was suggestive of reduced height of anterior pituitary gland with respect to the age of child. No other focal abnormality was seen. He was started on uncooked cornstarch diet and was able to maintain sugars at around 60 milligrams per deciliter. His critical sample values are as shown. His fasting blood sugar was 45. Fasting insulin, which should have been less than 2, was 3.8. His cortisol was normal. However, his growth hormone, which should have been more than 10, was 2.16. Rest other critical samples were within normal limits. However, his serum ketone was raised. His ABG was within normal limits. And his lipid profile, LFT and amount. His
Continue.
lipid profile and LFT and ammonia were within normal limits.
Now we are proceeding. What exactly are we contemplating with this kind of diagnosis?
Hypopituitarism.
Great. Who's that?
Anjali Gokand.
Any differentiation? Okay,
What was
great,
the liver?
madam.
How
तुम्ही
clinically
सगळ्यात
how?
असता. You are hematologist, endocrinologist.
I'm a general pediatrician. Because
Basically,
she said, yeah, she said doll-like
yes.
faces. So
Yeah, how clinically how big was the liver?
Can I please continue?
yeah, please.
Yeah.
Basically, a word about the glucose metabolism. As we all know, glucose is the most commonly readily available source of energy. And along with ketones and fatty acids, it provides energy for important pathways. Highest requirement of the glucose is in three organs, glucose, which is required by RBCs, brain, as well as muscles. Hypoglycemia beyond the neonatal period is rare, but has to be worked out to find out any underlying disease so that we can offer a proper treatment and the further plan for the next child. Timely evaluation is mandatory to have a good outcome. As we all know, it's an interplay of the hormones. With the low blood glucose and the high blood glucose, the pancreas have positive and the negative feedback mechanism. As a result of which, the glucagon, which is released by the alpha cells of pancreas, cause release of glucose into the blood, and insulin, which is released by the beta cells of pancreas, causing normal homeostasis mechanism in the blood. This all we know. That is why I'm going a little fast. Coming to physiology of regulation of glucose levels in the blood, basically it is hypoglycemia is nothing but abnormality in the fasting adaptation. As we all know that three metabolic systems are involved in the mechanism of hypoglycemia regulation of glucose. It is glycogenolysis, gluconeogenesis, and fatty acid oxidation. What exactly happens in glycogenolysis is glycogen is broken down into glucose 6-phosphate by glucose 6-phosphate dehydrogenase enzyme. One of the pathway in which it undergoes glycolysis and gives lactate as a byproduct, and glucose 6-phosphatase act to give glucose as a end product. As a result of which these are released from the liver and then transported to the bloodstream. Gluconeogenesis is nothing but production of glucose from the other sources like lactate, alanine, fructose, and glycerol. At the same time, fatty acid oxidation and ketogenesis, these are the pathways in which fats and fat stores go into the Krebs cycle by citric acid cycle from acetyl coenzyme A. And second pathway is beta hydroxybutyrate transported for energy production. These intermittent markers are used in the pathway to detect where exactly the damage is, where exactly the defect lies in the workup of critical sample. To maintain plasma glucose between may I please request others to mute?
Yeah, Pallavi
The
madam,
basic
please.
principle is to maintain the plasma glucose between 70 to 100 by a combination of insulin to utilize or store glucose and counter regulatory hormones to mobilize and release glucose. Now, what exactly this hormonal interplay is? As we all know, insulin is the main hormone which is active in fed state. This is extremely important. As a matter of fact, that hypoglycemia is preprandial or postprandial because the hormones are entirely different. Insulin is the main hormone in the fed state, which suppresses glycogenolysis, gluconeogenesis, lipolysis, and ketogenesis, ensuring that the blood glucose is well within the normal limit. Now, the counter-regulatory hormones are four important hormones: glucagon, cortisol, growth hormone, and epinephrine, which work in fasting state. It's extremely important to know this difference. Cortisol is important for stimulation of gluconeogenesis along with glucagon. Growth hormone is important for lipolysis. Glucagon is important for stimulation of glycogenolysis along with epinephrine, as well as it helps in the process of gluconeogenesis along with ketogenesis. So glucagon is the main hormone where we are going to use it in glucagon trial test. Epinephrine is responsible for glycogenolysis, lipolysis, and ketogenesis. Having understood this, this is the simple diagram in which all whatever we have discussed is shown. As we said, in the postprandial state, insulin is the only hormone which is required to maintain the blood sugar by all the mechanisms which have been discussed before. And in the fasting state, glucagon, epinephrine, cortisol, and growth hormone in this order so that the glycemia is properly maintained between 70 to 100. Now, the defense against hypoglycemia and endocrine regulation. The immediate effect from hypoglycemia is nutrient intake. Why this word is important, I'll come to that in the next slides. Liver is the main source of glucose metabolism, glucose production, with endogenous glucose production rate being 4 to 6 milligram per kg per minute. The first metabolically regulated defense against hypoglycemia is glycogenolysis. This is important because when the enzymes which are required for glycogenolysis, they are not active, then the child will present with these hours of fasting, 6 to 12 hours of fasting, in which hepatic and muscle glycogens are not converted into glucose. Fasting beyond this period stimulates gluconeogenesis, which converts glycerol and amino acids to glucose to provide glucose for 12 to 18 hours. So as a result of which the fatty acid oxidation pathway and amino acid pathways in which there are defective enzymes manifest after these many hours of postprandial time. During the latter part of this period, fatty acid oxidation takes over with the production of ketones. So this helps us to know that which exactly enzymes are going to be active at that point, as a result of which it is easy for us to interpret the results of critical sample. Now, what exactly is the relationship of hormone secretion to plasma glucose level? As shown in the left diagram, we have seen how the fourth counter-regulatory hormones are coming into picture with the pathways involved. Now, what exactly happens with the blood glucose? As the green line, green belt is showing that 70 to 80, 70 to 100 is the normal euglycemic control. So, insulin is switched off when the level is within this range. As the blood glucose starts, plasma glucose starts falling, first to come into the action are cortisol and growth hormone. Then, when the blood glucose level reaches 50 mg per dl, further hormones come into picture. As shown in the red zone, this is important that when the blood glucose becomes 50 milligram per dl, there is limited ability of blood-brain barrier for glucose penetration. At this point of time, it is very crucial that alternate fuels for energy like lactate, beta hydroxybutyrate had to get activated, and then there is further cutting down from the body by the other hormones, especially epinephrine on non-essential functions in the absence of alternate fuels. It's very important to note that when blood glucose has fallen to 30 milligram per dl, there is increased cerebral blood flow. The body is still trying to give maximum blood, as a matter of which the oxygen is made available and beta hydroxybutyrate levels also rise for alternate source of energy. Why have I made this capital is anaerobic oxygenation plays a role at this point of time. So unless and until, this is very important while managing the patient, that we have to ensure that the oxygenation of the brain is not hampered at the same time. Now, when prolonged fasting is there, what happens? Then the brain switches to 100% to ketones without compromising cerebral metabolic rate of oxygen consumption. This good the body has taken. My slides have, yeah. So further, if hypoglycemia, the moral of the story is hypoglycemia per se is not causing damage to the brain. It is the lack of fuel, which could be either glucose or beta hydroxybutyric acid or lactate or combined, which is going to cause the damage in the brain. Additionally, in addition to the lack of fuels for energy production, lack of oxygen supply prevents the utilization of lactate, which can dramatically worsen energy failure in the brain. When plasma level further drops below 30 mg per dl or still lower, then cerebral spinal fluid glucose level becomes almost zero, and in the absence of either ketones or lactate as the other alternate source of energy, the essential functions of the brain will stop and the cell death begins to occur. So it's very clear that not all the hypoglycemia patients are equally treatable. The responsible physician has to be efficient enough to assess what is the cause of hypoglycemia, because the management is going to change, the likelihood of the presence of alternate fuels, whether they are there or not, and the presence of good blood flow and oxygenation in order to understand the dangers of that particular hypoglycemic episodes. The importance of correctly identifying etiology of hypoglycemia thus affects not just the long-term approach of the management, but also the immediate approach. That is why it is very important to know that a single blood glucose level cannot be ascertained which will be damageable to the brain. We cannot swear and say below 30, this is the dangerous sugar, because we have to know that whether the alternate sources of the energy are available or not. And why? Efforts to define neurological outcome relative to blood glucose levels are not valid. When we go and find out the literature, why we are talking about hypoglycemia and why it is said that it is criminal to have a neonate to have a hypoglycemic convulsion. So because so many studies have tried to correlate the level of glucose and the damage to the different parts of the brain, but there is no consensus statement because of this. Now, what exactly hypoglycemia is after this dilemma? There are two terminologies as diagnostic hypoglycemia and therapeutic hypoglycemia. So what exactly is diagnostic? The level of glucose which is required to make a etiological diagnosis of hypoglycemia, and therapeutic hypoglycemia is the level of glucose which one should aim depending on what the diagnosis is to stay above the level of the damage to the brain. The concentration of glucose at which hypoglycemia causes brain damage is unknown, I repeat, and practically there is no such level. Now, once the hypoglycemia is there, how do we correlate what are the levels and what are the symptoms? Hypoglycemia leads to impaired CNS function. This is because of two main components, neurogenic and neuroglycopenic. As we can see, when the blood glucose is 100 mg per dl, basically insulin is started to be synthesized, released in the bloodstream. With 80 mg per dl, the body's negative feedback mechanism stops or starts declining in the level of insulin and its secretion. When the level reaches up to 65 mg per dl, as we already said, the four counter-regulatory hormones, glucagon, epinephrine, cortisol, and GH, they get activated. At 55 mg, we have neurogenic symptoms, which are nothing but palpitation, tremors, anxiety, sweating, hunger, and paresthesia. Mind you, these symptoms will tell the patient that now he has to have some sugar intake, the way normal adult diabetic patients keep on carrying their sugar or chocolates in the pocket and they start having the more sugary drinks. Once, this is very important that this feature may not be seen in the younger kids. With sugar further going down to 50 mg per dl, there is no insulin release. At 40 mg per dl, neuroglycopenic symptoms starts, which are headache, jitteriness, myopathy, muscle weakness, fatigue feeling, then weakness, seizures, apnea, coma, ataxia, and ultimately cardiac failure when the sugar is less than 20, or convulsions and permanent neuronal damage. This slide is just to enumerate the neurologic symptoms will appear when the blood sugar is still a relatively higher level. There is no definite milligram per dl level. Jitteriness, shakiness, tachycardia, pallor, hypothermia, hunger, sweating, weakness, and other glycopenic symptoms, which could be lit, smacking, or twitching in case of neonates, weak, shrill, or high-pitched cry in case of neonates, floppy, or apnea, or feeding difficulties. Now, what is the criteria to define hypoglycemia? Hypoglycemia should be considered in a wide variety of clinical settings with lethargy, seizures, encephalopathy, and headache in a little bigger children. It's classically diagnosed by demonstration of Whipple's triad, which is symptoms of hypoglycemia with documented blood sugar level of less than 60 mg per dl as defined here, and The symptoms are reversible or improvable after glucose response. So this is a Whipple's triad which is classically mentioned in the books, or as a matter of fact as a part of hypoglycemia diagnosis. But what are the fallacies? The fallacies in glucose measurements are: the glucometer measures whole blood glucose, the levels of which are generally 15% lower than plasma glucose. So what we are measuring with HGT is really not giving the picture of what actual plasma glucose is. Another important thing is glucose levels can be erroneously low in the setting of polycythemia, which could be in case of neonates, or dehydration in case of prolonged illness in the little elder children, and if it is done on a previously taken sample. So what important thing is, we have to have a highest degree of suspicion in all sick children, and as defined here as a Whipple's triad. Now coming to what are the clinical symptoms and signs, which we have already discussed, why pediatric age group stands alone differently. Less than 5 years of age will generally have hypoglycemic unawareness, as a result of which the children will not be able to respond and judge their neurogenic symptoms. Neonatal hypoglycemia is difficult to detect. Subtle signs like poor feeding, sleepiness, jitteriness occur in many non-hypoglycemic babies, in which the sugars are definitely normal, but there are so many other causes like intracranial infections, sepsis, or others. For more serious symptoms like lethargy, seizures, apnea, and coma, screening point of care of glucose should be performed, and hypoglycemia should be simultaneously confirmed by lab measured plasma glucose. This is extremely important, that we have to have a simultaneously laboratory diagnosed plasma glucose to document and decide further workup. Older children with acquired hypoglycemia are hypoglycemic unawareness, that we are going to see later on why this is very important, and different levels are there. So basically all neonates, infants, or children with neuroglycopenic symptoms or signs must have a documented plasma glucose concentration, and if it is less than 60 to 70 mg per dl, serious consideration for workup must be checked. As we have coming to the etiology, what are the etiologies? It can be either increased utilization or decreased production. So basically, what are the causes of increased utilization? Sepsis, cardiac failure, hyperinsulinism, which we are not going to deal with today. Increased utilization is either because of decreased production from substrate defect or metabolic defect. It is very important that accelerated starvation is the commonest form of childhood hypoglycemia, which is very well preventable. And increased utilization, or that we have already seen, decreased production is because of the different carbohydrate, lactate, fatty acid, and all those metabolic defect, as well as hormones, where the counter regulatory hormones are not having proper interplay. Coming to the most common glycogen storage disorders or glycogen related disorders, glycogen synthesis disorders are nothing but, as we have already seen, that it is the first response. So that is prandial hyperglycemia. This is very important, that these patients will have prandial after food because of reduced glycogen deposition in liver and fasting hypoglycemia as well. In contradistinction to other forms of glycogen diseases, storage diseases, hepatomegaly in GSD10 type of illness is absent in, there are different types of glycogen storage diseases depending on which hormones are affected. And another thing is, in glycogen storage disease, hepatomegaly is considered as one of the major important clinical feature. Now, whether hepatomegaly is present or not, accordingly, there are different types in which only liver is affected, in which muscle is affected, and in which liver and muscles both are affected. In hepatomegaly, when is affected, there is different approach whether these are ketotic or non-ketotic. This is how a simple approach is, rather than going into the detail, the deficiency which is there. But what is important is glycogen synthetase deficiency, or GSD0, is ketotic hypoglycemia with prandial hyperglycemia. So that means the child will have ketosis on ABG. Our child did not have. Glucose transporter 2 or GLUT2 defect, which are classically seen in Fanconi-Bickel syndrome, in which there is typically affection of renal tubules causing RTA and hence acidosis and renal problems. Coming to the glycogen disorders, in which there has to be glycogenolytic pathway also intact. So these patients will have ketotic hypoglycemia with hepatomegaly. Important amongst them are GSD1 and GSD3 because of different levels of glucose enzyme deficiency. As we can see, glucose 6 phosphatase in GSD1, which is the most commonest GSD type known. Debrancher enzyme in GSD3. Our patient, this type of patient does not have hepatomegaly immediately, and liver and muscle affection can be seen in the later part of the life. GSD 6 and 9 have got phosphorylase and phosphorylase kinase deficiency. Another
Ma'am,
important thing
sorry to
is
interrupt.
gluconeogenesis,
Uh, can
gluconeogenetic pathway, in which the other resources, as we have already seen, the amino acid, these are the substrate, alanine or non-glucose, fructose and glycerol. All these substrates are there, but the enzymes are deficient, especially is fructose 1,6 biphosphatase deficiency in the people who are basically dealing with GSDs. To mention the list, which is a complicated one, galactosemia and all others, which we need not go into the detail because that we as a general pediatricians are not seeing. A word about fatty acid oxidation. Fatty acid oxidation, we already saw glycerol and fatty acids are the other metabolic pathways which are involved. These
ma'am,
patients,
sorry.
as the pointer is classically showing, these are episodic, non-ketotic hypoglycemia with encephalopathy, myopathy, cardiac failure, raised transaminases, which our patient did not have. Our patient neither had ketosis. The diagnosis is established by acylcarnitine. Coming to this amino acid metabolic pathway, in which there is hypoglycemia, the physiological response to hypoglycemia is intact, but muscle mass and accelerated starvation is a diagnosis of exclusion. This we have already seen. Basically, this slide shows where insulin acts. A couple of points only to mention that this is a pump ATP channel where we are using the medicine later on. Having known this basis, how do we approach a child? Where exactly do we land up as a general pediatrician? It's very important to have a personal history properly. The first step, as we already know, the timing of hypoglycemic event is important, as we have already seen which
Ma'am,
path
5 more
or which
minutes.
other substrate is coming into. Yes, yes. So age of onset, neonatal infant child is definitely important depending on the presentation of different types of GSDs. Fasting tolerance or feeding frequency or night snack or morning ketosis. This is very important because as it is in the pediatric age group, the glycogen stores are less frequent, and the feeding in the early childhood, breastfeeding 2 hourly, 3 hourly, this is important to take the history as well as the manage the hypoglycemic episodes. Temporal relation with meals, fasting, postprandial and random, as we have already discussed. What is the relation to the fruit, like protein fruit, or if parents have noticed anything? Associated conditions or triggers, because accelerated starvation or excessive use in case of fever or other septic conditions is common. The recurrence helps to know intercurrent disease or fatigue because the muscles are always involved in amino acid as well as the other forms of hypoglycemia along with liver parameters involved. So as we said, in first it is important where how long the fasting is to be done. Hypoglycemia ka timing remains the first clue. Lab investigations play a pivotal role to reach a working diagnosis where we want to know what critical samples are showing. The presence of hepatomegaly is a very important differentiating clinical finding. And in case of hypoglycemia in otherwise healthy children, it is very important that we have to know whether there are any intoxications or factitious causes. Perinatal history of birth weight, gestational age, gestational diabetes, and any other form of perinatal distress and perinatal glucose requirement is important. In our case, this child has a traumatic delivery in which the forceps application was there, and the correlation of this was on MRI scan in which the anterior pituitary was relatively less as compared to his age, which was showing probably the pituitary as a whole could have also been affected. Growth and developmental milestones is extremely important to know. Intellectual disability, movement disorders, as we have seen in fatty acid, ketone pathways, epilepsy is there or not for other storage disorders, as well as associated with growth hormone, whether it is pan hypopituitarism or it is isolated delay. So we have to know the intellectual disability for hypothyroidism point of view. Family history of relatives with hypo or hyperglycemia, other metabolic disorders, consanguinity of marriage or previous miscarriages in which it was not detected. Physical examination do definitely play a role in which there are hyperpigmentation, midline anomalies in case of congenital adrenal insufficiency. Hepatomegaly, jaundice, cataract, absence of dental caries is very typical in hereditary fructose intolerance. Arrhythmias, heart disorders, as we said in fatty acid disorders. Organic acidemias will have ataxia and different kinds of movement disorders. So looking into this, it has to be seen as a symptom complex rather than individual symptom. The critical sample, a word to be mentioned, blood and urine samples have to be drawn. See, when we were discussing, there is a definite level of glucose, but for critical sample, the plasma glucose has been mentioned as a 50 mg or less. So to help in diagnosis of etiology of hypoglycemia. In plasma, we do glucose, insulin, cortisol, growth hormone. As we already have seen, these are the important hormones and these are the metabolic products: beta hydroxybutyrate, free fatty acid, acyl carnitine, ammonia, and LFTs. In urine, it is important to gauge which pathway we are proceeding towards, whether it is ketotic, non-ketotic with urinary organic acids. It's very important to find out whether we have insulin level which is increased in case of hyperinsulinemia, but because insulin has got a very short, it is a very labile hormone, that is why the precursor or C peptide is taken in the practical purposes. The principle is the critical sample has to be drawn at the time of spontaneous hypoglycemia, and if the lab parameters are not going to the lab immediately, then we have to make the child fast, and then the sugar has to go below 50 mg in a deliberately induced hypoglycemia. Then counter regulatory hormones ideally should be elevated and insulin has to go suppressed. The metabolic systems of glycogenolysis, gluconeogenesis, fatty acid oxidation, and ketone utilization should be underway with glucagon administration, and there should be no glycemic response as the liver should have utilized all the glycogen stores. In short, we have the approach towards ketotic hypoglycemia and hypoketotic hypoglycemia. In our child, there was a ketone was very mildly elevated with insulin, which should have been very low. It was elevated. So probably we were looking into the hyperinsulinism, but at the same time, as we have seen in MRI, there was no, there was anterior pituitary fossa being less active. So probably less as compared to the age. So probably we were dealing with also the somebody, Gokarna madam had rightly said it could be panpituitarism or it could be isolated pituitary hormone or growth hormone deficiency. This slide is very important. In short, it is giving an approach in ketotic hyperglycemia, ketones. If it is present, then we have to find out what is the lactate level. If the lactate levels are high, it is GSD type 1. If the lactate levels are normal, and if the liver is enlarged, then it is GSD 3 and 6. If livers are not involved, then probably we are dealing with definitely non-metabolic endocrine causes in which we have to deal with growth hormone and cortisol level. If the levels are low, mind you, both the hormones, growth hormone as well as cortisol, are important to find out whether it is hypopituitarism and not isolated hormones. And if these levels are normal, then this is accelerated starvation, which can definitely be preventable. Now, if the ketones are low or absent, then the way our patient did not have definitely high ketone levels or it was hypoketotemic episode.
2 more
Then if
minutes.
the urine reducing, then if the
Two
urine
more
reducing
minutes.
substance are present, then galactosemia, and if there is no, then we find out what is the level of insulin. In our patient, insulin levels were high, they were detectable, which would not have been expected. So probably, according to this pathway, we are dealing with either hyperinsulinism or hypopituitarism. The target, a very quick talk about a therapeutic hypoglycemia, because we have to deal with different conditions, and this slide says that the target is to keep the child above 70 mg per dl. The level is 70, though for investigation purpose it is 50. Exceptions are certain definite metabolic disorders. For example, fatty acid oxidation defects, the glucose levels have to be more than 80. The reasons are mentioned here. We don't want to have the insulin to prevent lipolysis. In children with GSD1, the levels are 70 to 85. This is very important for treatment point of view. This slide is extremely important, which mentions that why we have to be very aggressive about the glucose management. Recurrent episodes of glucose below 70 will blunt the release of epinephrine by autonomic nervous system, as a result of which the child will not have the awareness. The young adults with impending neuroglycopenic symptoms go and have their food by food seeking behavior. But after every episode of hypoglycemia, this counter-regulatory response is blunted up to 5 days. And if the hypoglycemia recurs in this period, the response goes on blunting more and more, which is known as hypoglycemia-associated autonomic failure, HAF. So how do we diagnose ultimately? We have sent all these samples. We have also sent a sample for NGS. NGS is nothing but newer generation
Ma'am, can we
sequencing.
wrap up the topic because we have two
Yes,
more speakers.
yes.
Yeah.
Basically, DNA analysis is important. Two aspects are there: targeted approach or untargeted strategies for whole genome sequencing. Management is basically to prevent symptomatic hypoglycemia, as it was mentioned that we are giving uncooked starch, cornstarch, as a result of which the sugar is maintained like this we are giving. It's important that these medicines are available. Diazoxide, if our patient turns out to be hyperinsulinism, then the patient would go on diazoxide. This is how it works, and there are certain pathways in which dopa PET scan or DPT scan is there, and then pancreectomy is the option. In our patient so far, a word about growth hormone deficiency, why we are still contemplating. In the young infant, most commonly presenting with hypoglycemia, prolonged jaundice, endor or microphallus, but our patient doesn't have. Growth hormone, basically in first year of life, doesn't come into the picture because growth is controlled by nutrition and genetic factors. So growth delay is not seen. Isolated growth hormone deficiency, we have to come to two failed growth hormone stimulation test using arginine and glucagon. So probably our patient is going to go with this test later on. Basically, concluding remarks, we have to have a critical sample properly. We have to be very aggressive in coming to a diagnosis. The flowchart always help us to find out whether it is ketotic, non-ketotic. As a general recommendation, fasting has to be avoided. Adequate carbohydrate is a must. Parents have to be told that the child, in case when the child goes into the catabolic state due to intercurrent illnesses, prolonged fasting, it is very important what they have to do. It is a multidisciplinary approach. There are no consensus or standardized diagnostic algorithms. So critical samples ultimately are very important. Lab data has to be appropriately integrated. The normal levels of hormones are not applicable to the critical samples, and innovative diagnostic techniques do help. A word about ketotic hypoglycemia. This is typically after the intercurrent illness in which all the hormonal pathways are intact, and only because we are not giving them the sufficient substrates. So it is diagnosis of exclusion, treatment is avoidance of prolonged fasting. And thank you so much. Dr. Alka Jadhav has been our mentor, and Madam has been pushing us to present these important cases to you. Otherwise, we would not have even reached to a proper, appropriate pathway. Thank you so much, IIP Palghar Academy, for giving us chances. This is our child. Thank you very much.
Thank you so much, ma'am. That was a very excellent presentation. Thank you, Madhavi ma'am, and thank you, Dr. Pranjal. and it was very nice to brush up our understanding about glucose metabolism and complicated role play of hormones and coming to a diagnosis. Thank you so much for sharing this case with us. So if we have any doubts, we can take. Otherwise, we can go to the next speaker.
Hello.
So, we will move on to our next speaker, Dr. Prasida Desai. Dr. Prasida Desai, ma'am, is a consultant microbiologist at Dr. Mopka's Diagnostic Center at Nalasopara. She is in charge of the microbiology department and manages the setup, which includes automated cultures, PCR, and gene expert for TB diagnosis. And she is also the infection control officer at Karuna Hospital, Borivali, and a certified internal auditor for NABL. Today, we will be learning the basics of PCR from Dr. Prasida, ma'am. Prasida, ma'am, are you on board?
Yes, ma'am. Yes.
Yes,
Over to
yes,
share.
ma'am. Yes, over to you, ma'am. We will mute.
Ma'am,
And I request the other participants other than speakers to please mute themselves and not disturb the talk in between. Sorry, sorry, ma'am. Thank you. You please continue.
I need to share my PPT. So it is not, hello.
Yes, ma'am.
Sharing is not turned on. Can you do that?
Yes, not.
Pallavi madam, can you make Dr. Prasida Desai host, co-host?
Co-host, yes.
Yeah. Pallavi madam, I'll call her. Huh?
Thank
Yes,
you.
ma'am.
So first of all, till our sharing gets done, I will thank IIP Palghar for giving me this wonderful opportunity. The speakers till now have done an excellent job, and it was very nice to hear such an extensive talk from them. Uh, and I thank Dr. Jayashree ma'am, gave the name, the ABC of PCR was suggested by her. So it's a wonderful thing to have a interdisciplinary, approach. So we also learn a lot of new things, and I think we also able to share whatever there in diagnostics with you all pediatricians. Uh, yeah. So now I think sharing is on. Can you see my slides?
Yes, ma'am. We can share your
Yes.
screen. We can see your
Yeah.
screen. Yes.
Yeah, we can see now.
Yeah. Okay. Yeah. So my topic is ABC of PCR and molecular diagnostics. So we all know that PCR has it has become a household name after COVID. And just the basics of PCR which are required for diagnosis. This will be outlined under following headings: introduction, advantages of PCR over other conventional methods, limitations of PCR test, a brief principle, because I don't want to bore you with the technical details. What is real-time PCR? What is RT-PCR? What are single-plex PCRs and multiplex PCR? We have different systems like open systems and closed systems. And also, we will then go on to CBNAT, which is again a buzzword, where two main CBNATs available in India are GeneXpert and TrueNat, which are also available with our lab. Then we have very important things in pediatric diagnosis is syndromic panels. So we will discuss in brief about biofire. So just to introduce, this test was invested, or PCR basically is a polymerase chain reaction where a small amount of DNA is it is multiplied so much that from one DNA you get multiple copies, millions of copies of that DNA, which was invented by Carey Mullis, who got the Nobel Prize in 1993. The invention was done in 1983, and it was a revolutionary step for a biomedical industry. So it has a lot of applications in genetics, in forensic science, in research, in biomedicals. Plus, it has a very important role in medical laboratories. The advantage of this PCR test, where you can just get a very minute amount of DNA and identify, it can be used to find out the genes from humans. It could be used to identify the genes from different organisms, can be used for DNA fingerprinting in forensics. It can be used for diagnosis of different organisms. So it is very sensitive test. It is very specific test. It has a multiple uses, very versatile test. As we all know currently, though there are multiple uses, I will be focusing mainly on infectious diseases diagnosis. So when infectious diseases diagnosis comes, we have only two main modalities. One is culture sensitivities and the other one is serology. So we know the cultures cannot be done for all the bacteria, all the viruses cannot be cultured, fungi take time to grow, Mycobacterium tuberculosis takes time to grow. So, as compared to that, this is a faster technology. Serology usually comes positive after 5 days. Again, there is a lot of false positives in serology, cross reactions, all are there. So, in that comparison, it is more specific and very advantageous fast so that it can be used for the uh, patient treatment. So, the next is this in any test comes with pros and cons. So there are limitations. What are the limitations? One major limitation is the cost. It requires a lot of infrastructure. It requires a lot of technical expertise. So any technician cannot do. A lot of training is required. And then the main chances, we have to be very careful when we are handling the PCR labs. Even a minute contamination can make a problem, and that difficult to remove that contamination and can give false positives. Very important take home message for PCRs. Whenever you're ordering any PCR, it is usually for diagnosis. It is not for follow-ups. So suppose a PCR comes positive, like for example, in COVID, we use a lot of PCRs. So once it comes positive, it will remain positive for a long time, even after the disease is cured, because it will even dead bacteria, dead viruses will be detected by them. So if, for example, a C. diff once comes positive, there is no need to repeat the test to see whether it is cured or not. Similarly, if gene expert is positive, it will remain, even if it comes positive later on, it should not be used. What you need to follow up by cultures. Only thing where you need a follow-up PCRs would be a quantitative PCRs where you're detecting viral loads and you want to see, like for example, for HBV viral loads, HIV viral load, HCV viral loads, whether they're going up, down. Those quantitative PCRs only will need to be repeated. Otherwise, repeat PCR for follow-up has no role. Now, in brief, the principle. So PCR is basically your DNA, which is a double-stranded DNA. It is like a zip. So like a zipper, we have to first open it, make two copies. Then this copies, the second strand is joins to the first strand, and then this cycle repeats. So you need a lot of components. First is your DNA sample. So we can have DNA sample extracted from multiple sample types, like from blood to sputum, bile, tissues, pus, etc., fluids, etc. So once the DNA sample is extracted, that sample is mixed in a small PCR tube. In this particular tube, everything will happen. So the primers. Now primers are the small fragments of nucleotides which bind, which are specific to the target gene. So suppose we are going to detect an HLA-B27 gene, it will be specific to that particular gene. If you want to detect an RPOB gene, it would be specific to that gene. Then what are the basic building blocks of any DNA? Is ATCG, the nucleotides. Those are required. There is a specific enzyme which is Taq polymerase, which is required for extension of the DNA strands, and other reagents like buffer and all. What happens is basically there are three steps. One is denaturing. Denaturing is basically melting of DNA or separation of DNA strands. It occurs at very high temperature, 95 degrees centigrade. All this thing happens in this thermal cycle. Now I'll just tell you why it is called thermal cycle, because here you are getting a very high temperature where your strands are separating. So these strands, then the temperature goes down. So this machine reduces the temperature, and these two strands which are separated, the primer will go and bind to the target DNA, and then again the temperature changes, and the polymerase acts, and the new strand of DNA is formed. So from one DNA you get two DNA strands. So this is your three steps: nucleic acid denaturation, where two strands are physically separated at high temperature. The second step is known as annealing, where temperature is lowered and primers bind to complementary sequence of DNA. And then there is extension stage, where the two DNA strands become templates for the DNA polymerase. And then you get a double stranded DNA. So now this is a chain reaction. So now the two strands are formed, the same procedure will be repeated, and you will get a four strands. These four strands will then be the template for the next eight strands. And so usually we get 40 to 45 cycles, and in those cycles we get a million copies of DNA, which we detect. Now in our we were talking about real-time PCR. So currently, whatever PCRs we are using in diagnostics, which are mostly real-time PCR, almost 95% of the cases. Now, why they are real-time PCR? So this primer is attached with a fluorescent probe, and whenever the new DNA is formed, this fluorescent probe or fluorescence increases, and there is a sensor which detects this increase in fluorescence, and the graph is plotted. So this happens in real time. So what happens? There is no post procedure, anything needs to be done, and you get the results within 2 hours. So usually a PCR cycle is around one, and it depends on the kit or depends on the parameter. So it could be anything from 50 minutes to 1 hour to 1.5 hour to 2 hours. So accordingly, within 2 hours, we will get the result once we have a DNA extracted. So overall, one PCR test will take around 3 to 4 hours. Now we talked about RT-PCR. Now the RT-PCR is a bit confusing term. Whatever we are doing is real-time PCR, and it is known as also qPCR. So what is RT-PCR? So we know this whole thing started from the DNA. So for the PCR, we need a DNA. But if you remember, we had SARS-CoV pandemic and we had H1N1 pandemic. Both these are viruses which are RNA viruses. So we have to multiply the RNA of these viruses. So to do that, we will first need to convert this RNA into DNA, which is called as complementary DNA, and then the PCR will proceed. So there is an additional step for these RNA viruses, and that is known as reverse transcription. So for HIV, for flu, for COVID, we will have a reverse transcriptase PCR, which in short is known as RT-PCR. So RT-PCR is reverse transcriptase PCR, while all other tests which we are doing, the methods which we are using is real-time PCR. So what it gives? It gives us simplicity, specificity, and what you don't need is post-PCR processing, which was required previously. You can detect very low copy numbers. And what we have is qualitative PCR and quantitative PCRs. So qualitative PCR will just give you whether this particular target is detected or not detected, while quantitative PCRs would be giving you viral loads. So it is mainly used for detecting HIV viral loads, HCV viral load, HBV viral loads, etc. There we have a standards, so that can be compared to give an exact number of copies. What we have in otherwise CT values, these are not quantitative, but I will just explain what is the what are CT values and how do we interpret them, whether they are actually give you high number, low number, or it is not. That I will discuss later on. So what is the advantage? Highly, it is very rapid test. You can detect viruses. There is no other test available for viral diagnosis. Earlier treatment can be given. So once we know that patient coming with URTI and we have done a flu PCR or a flu panel, and we get to know that whether it is if it is flu A or if whether it is RSV or it is COVID, we can treat the patient accordingly. If we come to know it is a bacterial infection, then only we will start antibiotics. So it will help us to spare antibiotic with confidence. So that will prevent antibiotic resistance. Also, because we are detecting earlier, we will also help in preventing the outbreaks as we did in COVID pandemic. So apart from the infectious diseases, it is used for genetic disease diagnosis like prenatal diagnosis and screening of neonatal genetic diseases. It can be used for detection of oncogenes and management of cancers. So I'm not going into that. I will be basically focusing on infectious diseases. Now we know the terms like singleplex PCR, multiplex PCR. Simply a singleplex PCR will detect only one target. So for example, it might be an HLA-B27. That PCR will have only one gene HLA-B27 and it will be detected. Now what we get is this type of graph. This is where the fluorescent signal. Now here is this is a lag phase and here the fluorescent signal has started rising. Now these are the cycles which we can see at the bottom on the x-axis. Now this is a lag phase, this is a logarithmic phase, and this is a stationary phase. So when the logarithmic phase starts, there is a threshold which is set. Now this threshold, when your graph crosses this threshold, it is called a cycle threshold. So here, as we can see, 25 is the cycle where this threshold is been crossed. So this is your CT value. Now, in general, when your DNA load or nucleic acid load is high, you will get a earlier cycle threshold. Well, if it is low, you will get a later cycle threshold in general. But then when you're collecting the nasopharyngeal or oropharyngeal swabs, there are a lot of factors which will affect, like how the sample is collected, how it is transported, and lot of variables are there. So only cycle threshold cannot be used as a quantitative measure and cannot just tell you how much viral load is there. It will only tell you what was the nucleic acid material present in that particular sample. With every PCR, for every sample, there is a control, because if the DNA is not there, this cycle will not rise. Like for example, here, there is no cycle is rise. What we are seeing here is a internal control, which is a process control. It is from human cells. So whether I have collected the sample, if there is a nucleic acid, if it is a oropharyngeal sample, if the sample is not collected properly, the cells from the human body will not be there, and then this test would be invalid. So this internal control always has to be present to get the test valid. Now when we say singleplex, now there is also something called as multiplex. Now why multiplex? Because it will help us in a single test to detect multiple organisms. Usually, flu would have similar upper respiratory tract infection, cold will have the same type of symptoms, but we don't know which organism it is. So this test, I mean, this particular multiplex will have multiple targets like influenza A, B, RSV. Now in influenza, again, there will be separate targets for H3N2, H1N1, etc. So we will know exactly which organism is present. So this is your multiplex PCR. Now, we also know that there are different type of tests available. There are open systems and there are closed systems. Now, if we go for PCR, the main hurdle of starting any PCR setup is it is very costly affair because it requires a large space It requires 4 separate rooms. It requires multiple machines, machinery, dedicated equipment for each room, and we have to prevent the contamination, we have to maintain the workflow, etc. So it is that's the main barrier to start any PCR lab. But because of COVID, we already we have multiple PCR labs available in India and functioning. So now the stage has come where more and more molecular diagnosis can be used in a day-to-day life. Now, what are the advantages of these open systems? This is a one-time investment where there is, a lot of investment for space, infrastructure, machine. It needs expertise for the reading of the results as well as to perform the test. There are chances of contamination because once the contamination comes, it is very difficult to remove that contamination. A stringent QC is needed. And when it comes to a real life scenario for a clinician, we have to do a batch testing. We cannot put a single sample. So what happens is the turnaround time increases. So if we will have a one batch for particular test, say flu, that time only the sample can go. So you might get a result once in a day, or some parameter might have twice. Like for example, HLA-B27, if it is done once in 2 days, you will get the results after 48 hours. So those are the disadvantages. But the
Ma'am,
advantages
5
when
more
we have a
minutes. Is that okay?
okay, so when we see the scalability, it can be scaled to we can test multiple samples, like not only 10 up to 96 samples can be tested together. Flexibility, we can use multiple different types of test. We can have multiple parameters added to our menu. We can have different, if the new technology or better kit comes, we can adopt that kit. Plus, over a long term, the cost per test becomes less. So it will be advantageous for the patient also. But but this is not possible for all the setups. So what we have is CBNAT, or cartridge based nucleic acid amplification test. And these tests, the main common test which we have is Gene Expert, which is common around 2006. It was first came in market, and by around 2012-13 it was widely adapted. Now, this has what happens is, whatever I told you, whatever different uh, rooms which we require, different, this everything comes in this same single small cartridge. So it replaces this all things, and it's a miniaturized laboratory. And it was a really revolutionary test which helped us in our TB diagnosis. So TB, just in a brief, I will explain you what was a TB, MTB RIF, and MTB RIF Ultra. So when we started Gene Expert, there was uh, government subsidy to Gene Expert, so it was available at lower cost, also subsidized rate for the patients, and it has an advantage of giving tuberculosis present absent as well as rifampicin present absent. Rifampicin being a marker, surrogate marker for MDR-TB. MDR-TB, which is INH and rifampicin both resistant, but only almost it was studied that only 6% of them will have INH monoresistance. But probably in India, we still might have more thing. At that time, as per program, MTB RIF, if it gives rifampicin resistant, it was considered as MDR TB and treated accordingly. So TB being a very important public health concern, and the treatment needs to be proper, this has revolutionized our TB diagnosis. Now, it is a semi-quantitative test, and what are the samples? It's a WHO endorsed test. So there are multiple studies done, and it can be used for pulmonary and extrapulmonary samples as well. Whenever clinical suspicion of TB is there, who has not received AKT, or less than 3 days of therapy in last 6 months is eligible candidate. So TB becomes the first line treatment, first line diagnostic step for when TB is suspected. Uh, this is a modular and it is very easy to perform. It doesn't require a technical expertise. On the other side, it is very robust system, so it can the accuracy is very good. The sensitivity is very good because the limit of detection, that means the least amount of bacterial load which can be detected by this particular test was 116 in the MTB RIF cartridges previously. Now with Ultra, it has gone down to around 13 CFU per ml. So only 13 bacilli can be detected. If you compare it with the microscopy or culture, it has a very significant advantage. Now, what we have seen is also because of that, the detection in even body fluids and possibly bacillary cases like tissues have improved. So this type of tests have reduced the cost, it has streamlined the operations, and it can give you results within 2 hours. So it's a rapid actionable diagnostic test. What you need is a sample volume which is very low, around 1 ml sputum is adequate. Apart from, and if you're not going to send a sample immediately to the lab, it has to be stored at around 2 to 8 degrees centigrade. Once you give a sample, it has to be tested. Maximum 7 days you can store it before testing. So if you want to add on test, it is 7 days. Sample types which can be used: pulmonary, sputum, bile, gastric lavage, ET secretions. Uh, from extrapulmonary, FNACs, pus, tissues, body fluids, all the body fluids, especially CSF, has a very good results. Pleural fluids, we have seen a lot of positive cases. And the next is urine. Now, urinary TB is very difficult to diagnose. It has a very dilute sample. Like in urine, the number of bacteria would be very less. So, if you send a 30 ml sample, that will not be adequate. What we require is a 3 consecutive days, early morning samples, fully voided. So that is again a very important message I would like to give, that if you are suspecting urinary tuberculosis and want to send sample, please send at least 3 consecutive day early morning fully voided urine samples, whether you want to do gene expert or culture. And for all the extrapulmonary samples, it is always advisable to do both the test. Next is,
Ma'am,
this is what we see,
2 minutes,
the graph.
ma'am.
If it is negative, if it is positive, it gives you low, high, very low, and medium, and also gives rift resistance, detected or not detected. When it comes to if this is rift resistance detected. If it comes trace, there is some, because I told you that 16 is the limit of detection. So sometimes very low bacterial load is also detected, especially in pleural fluids from tissue samples. In those cases, rift resistance, because there is no adequate DNA material available to detect the rift resistance, we get it indeterminate. And then in those cases, what we have is we have to rely on AFB culture. Once it comes positive, then we can go ahead for further testing whether it is a what is the status of rifampicin resistance. Now, what happens is, usually when we get a gene expert positive and rifampicin results, we also like to know what is the INH status, because INH monoresistance also needs to be treated separately because it will not be picked up by the gene expert test. So what we had normally, we had a line probe assays which are available, which requires a post PCR processing, and we will get a different bands. On that, we will see whether which type of mutation is there, whether it's a wild type band or mutation type band. And we can see RPOB gene, which is for rifampicin, CATG, and INH gene. CATG is for high level INH resistance, and INH is for low level INH resistance. Thus now, previously only line probe assay was available for INH resistance detection. Now we
Ma'am,
have the same
ma'am,
test, just 5
ma'am, we
minutes.
have only 2 minutes. Please,
Yeah,
we have another speaker. Yeah.
yeah. So, INH resistance, if it is positive, then we can go ahead to do something called as XDR, which is available again on Gene Expert, and where we can detect INH along with other tests like fluoroquinolone, amikacin, kanamycin, capreomycin, and ethionamide resistance. And uh, but for this test, we have to have at least medium or high load. We cannot detect it, we cannot use it for very low trace and low loads because it has a more limit of detection. So this was a resistance, INH resistance detected and fluoroquinolone resistance detected. Here we have no resistance, only MTB detected. The other test which we can use is on another cartridge-based system, which is small bio. So we have only INH resistance detection, and I would encourage you, whenever you get gene expert positive, kindly ask for INH resistance, because again now the new protocol which has come by the RNTCP tells you to do the INH testing also. Now, what is the other test which we can do on Gene Expert? MRSA screening, which would be important for the hospitalized patients who are for ortho cases or for CABG cases. For SARS-CoV-2, flu RSV, C. difficile, again, not important probably in children, but yeah, the multi patients on long-term hospitalization and antibiotic-associated diarrhea, C. diff is important. HBV, HCV, HPV, and CRE. CRE is again carbapenem resistant enterobacteriaceae, which can be detected. Now, another CB-NAT machine which we have is small bio. The throughput is around 40 to 48 samples per hour. Now, it has 4 bays. It is a random access. So when we have a multiple, and it has a very wide test menu. All these are study systems, so the chances of false positive or wrong testing, all these are minimized in these systems. What we have in it is, apart from MTB RIF, it has INH, which I said very important addition. For fever, it has multiple tests available, dengue, chikungunya. As we know, for chikungunya, we don't have any specific test. We only have ELISAs, which might not be positive many a times. So for chikungunya PCR, there are many cases of chikungunya detected because of PCR, dengue chick PCR. And many times there is a co-infection also occurs. So dengue and chikungunya PCR might be important for a diagnosis of fever patients. Another thing is the panel approach. We have a salmonella in it. Flu, flu we have flu, RSV, H1N1, H3N2. Again, for tropical fevers, leptospira, which is a very important test. Again, no diagnosis is available. A very reliable test is not available. We depend on serological tests, which take time, and leptospira deteriorates very fast. So, leptospira PCR has been very important in diagnosis and patient management, where we have been able to save a lot of ICU patients and get them back. Uh, then other tests are available like Shigella scrub typhus, which is also present in the Virar belt. So again, that is one of the DDs of fever with rash that can be detected in this machine. HLA B27, hepatitis, all the hepatitis viruses, HPV, CTNG, that is chlamydia, trachomatis, Neisseria, gonorrhea, which again in pediatrics it might be causing conjunctivitis. So here you can use them. Group B, Streptococcus and HSV. For the one HSV could be used for CSF samples, neonatal meningitis cases. So this is again a small screenshot of TrueNet PCR. And then we come to syndromic panels, where syndromic approaches for one particular syndrome, whatever possible, most common organisms are there, their multiple targets are detected together. So, for example, a fever, so that we have a tropical fever panel, if fever with rash panel, meningitis, pneumonia, uh, gastroenteritis, or upper respiratory tract panel. So, similarly, this type of panels are there. Now, these panels this can be done in open system as well as closed system. So the closed system which are available are BioFire and QIAstat. Now, biofire is very something which is again a very important and game-changing type of system, because we are going to get the results within 1 hour, and where you can see the comprehensive grouping. We can detect viruses, bacteria, parasites, yeast, and also the antimicrobial resistance genes together. So this is a small compact machine. Once the sample comes, the results are available within 2 hours. So again, here you have a targeted, expanded syndromic approach, broad grouping, which have good overall performance, good positive predictive value, negative predictive value, and basic important molecular testing is getting an actionable answer for the clinically relevant time. So you get a fuller picture, evidence-based management, and you can have a proper informed patient management decisions. Now, all these molecular tests, they cost something, but this cost is, if you compare it with other tests, like other costs, cost of hospital stay, cost of delay in
Ma'am,
diagnosis.
can you please wind?
Yeah, this is the last slide. And it will, using the right test the first time to detect multiple pathogens may result in reduced appointments, reduced testing, unnecessary testing, improve the patient comfort, experience, and convenience. These tests help in antibiotic stewardship, prevention of infection control, early isolation of patients. These are the different panels which are available. The cost benefits, faster recovery, and avoidance of costly diagnostics and costly treatments. And we need a proper sample collection. So that is very, very important whenever you are doing any test, and transporting in a proper cold chain using a proper medium that is required. So with that, thank you all for giving this opportunity, and I'm open for any questions. Thank you. If there are any questions, I will like to take them.
Thank you so much, Pratima ma'am, for this excellent talk on PCR. I think mm, mm, right now there are no questions asked yet. Uh, if we don't have any questions, we can move to the further topic. Thank you so much, ma'am, for the talk. And now we will invite our last speaker for today, Dr. Aniket Deshmukh, sir. Uh, Sir is a consultant pediatric hepatologist, gastroenterologist, and liver transplant physician at Nanavati Max Hospital. And sir has been he has number of publications in national and international journals, and he is a receiver of Young Investigator Award in 2003 and 2023 and 24 both. And now we'll be seeking unmasking pediatric fatty liver disease from sir. So the over sir can start.
Can you see my slides?
Yes sir, yes sir, we can
Yeah.
see your slide.
Hi, good
Sir,
evening,
we can
everyone.
see. Yeah.
And
Good
thank you,
evening.
IIP Palgar, and thank you, Deshpande madam, Gokena madam, Joshi madam, Barrett sir, for having me here. So after three excellent talks, I think, and due to time constraint, I think I will like to keep my talk a little crisp and short. And आताच just last Saturday World Liver Day गेला. So this topic, pediatric fatty liver disease, I would like to continue in the view of World Liver Day. And I can tell you in next 15 or 10 years, this will be the one of the most common etiology which you will be seeing in your OPDs with transaminitis. So any other cause with transaminitis, this will be one of the most important DD. So today's talk will have some, I would like to touch upon just the theory. I'll just, brush upon, and I will discuss some of the unusual cases which can be encountered with fatty liver. So, non-alcoholic fatty liver diseases, NAFLD, is a spectrum of fatty liver disease in individuals without alcohol consumption, ranging from non-alcoholic fatty liver to non-alcoholic cirrhotic hepatitis, which can follow to cirrhosis. So, what is NAFL? Just fatty liver is greater than 5% hepatic steatosis without any liver injury. NASH is greater than 5% hepatic steatosis with some liver injury, which ultimately can cause cirrhosis. So NAFLD was an old term. There are so many terms right now. No, this is another term which is not used much in pediatric, but in adult population, they have defined as MAFLD, that is metabolic dysfunction associated fatty liver disease, in which they have defined any hepatic steatosis and with an individual with obesity or overweight defined by BMI can be a MAFLD patient, or hepatic steatosis with type 2 diabetes mellitus can be a MAFLD patient, or hepatic steatosis with a lean individual with any of the following two, that is waist circumference more than the 90th percentile, hypertension, hypertriglyceridemia, low HDL, pre-diabetes, any of these two can be a patient of MAFLD. However, the latest definition, which has been defined in 2024, a new entity, basically MAFLD, and MASLD, that is metabolic dysfunction associated steatotic liver disease, has been defined, and a pediatric definition has been they have devised, in which steatotic liver disease identified by imaging or biopsy includes one of the five, that is BMI more than 85th percentile, or waist circumference more than 95th percentile, or a fasting blood sugar more than 100, or HbA1c more than 5.7, or hypertension according to the age, or hypertriglyceridemia and low HDL. So any one of the following, still the patient can be labeled as MASLD. So this is a new terminology. No, nowadays no one uses NAFLD. Everyone is using MASLD as a new terminology. So this is just a busy slide, but this is a compilation of all the prevalence of NAFLD or MAFLD in developed countries. You can see USA, Germany, China. The overall compilation shows that around 5% to 70% of children can have NAFLD. Most commonly in obese children in developed countries, they have seen that it was high. In lean individual, it was around 3 to 20%. Similarly, this is a table showing in the developing countries like Pakistan, Iran, Brazil, India. Here you can see in India, in fact, overall the percentage in some of the studies, this is a old study, but however, the percentage was 10%. Similarly, this is one of the latest study in 2018 from Delhi, in which they saw in overweight individuals, 62% had NAFLD features. So to compile all over the whole data, pediatric NAFLD prevalence in general population more than 10 to 25% of patients. In obese children, around 60 to 80% of patients. In fact, this is a study which we did last year, in which you compiled with our Canadian counterpart, which you compiled data of Indian children with Canadian children, and what we saw in Indian children, the family history of steatotic liver disease, hypertension, dyslipidemia was quite high than the Canadian counterpart, and also Indian children. The AST/ALT was much higher than the Canadian counterpart, and HDL was lower than the Canadian counterpart. So we don't know the why it is there, but if you come, the Indian NAFLD children definitely had higher degree of steatosis compared to the Canadian children, most probably due to genetic factors. So this was a study which we had published last year in comparison with two countries. Just a touch upon pathogenesis. As NAFLD is a multifactorial thing, now there are multiple factors which are involved. Diet, obesity, high fructose, intestinal dysbiosis, that is gut dysbiosis. The latest literature shows that the different types of bacteria are known to cause NAFLD or MASLD. So this is also an risk factor, even genetics and prenatal and postnatal factors, typically in pediatric. Prenatal factors are gestational diabetes mellitus, increased BMI in pregnancy, high fat diet, low birth weight are known to cause mitochondrial dysfunction, endoplasmic reticulum stress, oxidative stress, increased de novo lipogenesis, and decreased beta oxidation, ultimately causing NAFLD. So just touch on pathogenesis. So this is a beautiful diagram in which you can see this is a healthy liver, this is a fatty liver, which goes into fibrosis, then cirrhosis, and sometimes can go into liver cancer. So this is a diagram, but usually if you ask me, this usually takes 20 to 30 years to develop. So, there's a beautiful study from which I've not mentioned in Germany, which they saw that in the 30 to 40 years, people with NASH cirrhosis, when they find out their pediatric, like the investigation in their childhood, they saw that around 80% had grade 1 to grade 2 fatty liver since they're 10 years of age. So my point is, this fatty liver slowly progress over 20, 30 years and ultimately can cause cirrhosis after 20, 30 years. And in fact, currently, you will ask me in India also and in US also, NASH, that is NAFLD, is one of the common, like after alcohol, NAFLD is one of the most common cause of liver transplant in adults. So it is such increasing at high alarming rate. So in pediatric, however, it is the cirrhosis is not so common. Usually, this children they develop cirrhosis after 20 years, 30 years. So these are some of the risk factors, which I have mentioned earlier: gestational diabetes, maternal obesity, metabolic syndrome. So metabolic syndrome is basically compilation definition in pediatric is like waist circumference more than 90th percentile with any one of the following: there is hypertension, diabetes, HbA1c more than 5.7, low HDL or hypertriglyceridemia. This is a definition of metabolic syndrome. Even low birth, this is very, low birth weight babies are, there is a study in which they have found out that this LBW babies are ultimately a high risk factor for causing NAFLD. SGAs, high fructose consumption, yes, diet, and decreased physical activity are some of the risk factors. That this is just a theoretical. These two genes are quite common to cause NAFLD, especially PN and PL3. There's a study from Delhi in which they saw in NAFLD children around 20% had this gene positive. So just for theoretical purposes, no need to remember it. So what is the difference between pediatric and adult? Yes, antenatal and early childhood exposures is different in pediatric population, which we saw the risk factors like maternal factors, environmental and socioeconomic factors. Earlier it was said that NAFLD or MASLD, which was seen in upper middle class or higher class, but I can tell you nowadays I'm seeing middle class and even lower middle class having NAFLD. But however, this is one of the factors. A different histology, yes, there is a histological difference between pediatric and adult. The steatosis is normally seen in zone 1 in children and adults in zone 3. And metabolic liver disease. Most of the pediatric fatty liver disease are sometimes have secondary fatty liver. So most of them sometimes have a metabolic cause causing a fatty liver. So this is very important in pediatric, which is not there in adult. Also, you can see this table. Only 1 to 2% can develop cirrhosis in children. Adults, yes, 5 to 10%. I can tell you this is, I think, much more than 10%, in fact. Uh, NAFLD and other diseases, yes, pre-diabetes and diabetes much more prevalent. These are the statistics from most of the studies. They saw that in NAFLD children, 20 to 30% had pre-diabetes to diabetes, 5 to 10% had increased prevalence of hypertension, 50 to 60% had metabolic syndrome. There was a high risk of hypothyroidism. There is a high risk of depression and low self-esteem and psychiatry issues. So all these etiologies or diseases are sometimes associated with NAFLD, and this has to be looked upon if any case of NAFLD, and you have to make sure to rule out all these causes. So whom to screen? This is a beautiful slide. In fact, this is a part of an Indian society guidelines. Fortunately, I am a part of it. So what we saw that more than 8 years, any child with obese child with BMI more than 95th percentile or BMI with 85th percentile with either waist segments more 70%, pre-diabetes or diabetes, dyslipidemia, hypertension, or family history of OSA has to be screened for NAFLD. I will tell you how to screen, but these children have usually any of these features have to be screened earlier. If there's severe obesity, like severe obesity, severe BMI, hypopituitarism, and family history of sibling with parents with NAFLD. This more than 8 years, actually, it is an arbitrary figure. But if you'll ask me, most of the studies have mentioned, even the North American guidelines have mentioned 8 years. So the most important point here is in practice, any child with less than 8 years with a fatty liver disease, you have to think of metabolic liver disease. So basically, any child with less than 8 years with fatty liver, you have to rule out other causes of fatty liver. So this is an important point of this slide. And more than 8 years, all this, if they have to be screened. And usually, yes, they are this patients are commonly discovered by accident. They have vague symptoms, recurring abdominal pain, constipation, abdominal liver biochemistry, or abdominal imaging done for other reasons. So they are usually accidentally found out. These are some of the red flag signs mentioned in Indian guidelines. These children, as I said, we have to suspect some metabolic liver disease if any child less than 8 years, not overweight or obese. So this is a special category known as lean NAFLD. In fact, in Asian population, there are some individuals who are lean. In fact, they're underweight and they are known to they are known to have a non-alcoholic fatty liver. Such children, in fact, and adults are in fact are a higher progression of causing cirrhosis. This is a special population seen especially in Asian population. Any child with growth failure, any child with development delay, any syndromic features, splenomegaly, synthetic hepatic dysfunction, or positive family history of liver disease and multisystemic involvement have to be ruled out for secondary causes of steatotic liver disease. So how to screen? So these are the non-invasive markers which are important. Invasive markers, I will tell you where it is important. Usually we don't do this. So ALT, USG, transient elastography, fibroscan, MRI, and non-invasive indices like non-invasive markers. I will tell you for your future slide the full form. So ALT, if you'll ask me in USA, the criteria which they follow, any child usually more than 26 in males and more than 22 in females is abnormal in USA. This is found out from a beautiful study from USA in 2010, in which they had screened around 20,000 children. So this is the normal criteria used in USA. In NASPGHAN guidelines, usually they have mentioned ALT cutoff twice the upper limit. Let more than 45-50, you have to screen. So usually they are also considered in children more than 25 as the criteria. There are no cutoffs for Indian children, and no, even the Indian society, we have not decided any cutoffs. But in practice, what we do in most of the centers in India and also in UK, uh, any male child more than 35 and any female more than 30, any girl child more than 30 is considered as abnormal transaminitis. So you have to investigate for these children. Similarly, USG, yes, we all know USG. This is normal ecotexture, grade 1 fatty liver, grade 2 fatty liver. This grading is basically based on the diaphragm and the portal vein status. The radiologist gives grade 1, grade 2, or grade 3. However, the point to be noted is sometimes USG may miss milder steatosis, especially involving less than 33% of hepatocytes. This is a machine known as FibroScan, a transient elastography. This is the machine usually, and this is the probe. So this probe is usually kept on the right hypochondrium near the liver area, and we usually 10 readings are put. There's a button we take 10 readings, and usually this is the values which you will usually see in the report. So what is CAP? CAP is controlled attenuation parameter. That is, it tells us the value of steatosis. That is a fat percentage in the liver. And this is quite high. In pediatric, usually what we see in Indian children, there are no cutoffs, but there's a study from UK in which they have found out usually the children should have less than 240 as the normal values for CAP. So this is definitely an abnormal value. Similarly, this E, that is kilopascals, a median, shows as a fibrosis, which is 29.6. So this is also high. There are also some gradings in the children. Usually this value should be less than 7. Ideally should be between 4 and 6, but less than 7. If it is more than 7, then definitely there is fibrosis. If it goes on increasing the value, more than 14 is considered as F4 fibrosis. So there are some gradings, but to remember, this should be less than 240, this should be less than 7. So this is how the report of fibroscan usually sees. So this is a good non-invasive marker. And these are some indices. Nothing to, I can just tell you this is on a FIB4 ELF. Just to remember, I think this is the most easy index. Was APRI, that is AST to platelet ratio index, and more than 1.5 is usually shows that there is higher degree of fibrosis. The point to be noted is among the non-invasive markers which I showed you, there is no single entity which can be used to correctly diagnose NAFLD. So to diagnose it, you have to do multiple tests, like you have to do a ALT, you have to do a USG, sometimes a fibroscan to diagnose an NAFLD. And sometimes out of this four, EPRI is the most common, which is used in pediatric. So liver biopsy. Usually we don't do liver biopsy, but these are some of the indications when liver biopsy. This is the North American guidelines. Indian guidelines, I will tell you where they are mentioned, but these are the guidelines in which they have mentioned that liver biopsy has to be done, especially if you are thinking of alternative treatable etiology, especially in less than 8 years or more than 8 years of suspecting other etiologies. Whenever there's ALT is more than 80, or there's splenomegaly, or there's diabetes mellitus or panhypopituitarism, you have to go ahead with a liver biopsy before starting any medical treatment or surgical treatment as a part of a clinical trial, family history of NASH, and Once you're given a 3 to 6 months of dietary treatment and still there's transaminitis, you have to go ahead with a liver biopsy. So these are the North American guidelines. In Indian guidelines, we have just mentioned that uh, if there is a family history of NASH or if there's transaminitis after 3 to 6 months of dietary treatment and there is no improvement, then you have to go ahead with a liver biopsy. This is just a theoretical photo, just to show that how usually the fat sees this is steatosis. Here you can see there's some inflammation. This is fibrosis. This is F1 fibrosis. This is how the swelling of the cells happen, hepatocytes. So management, just to touch upon, the most important of this is this lifestyle changes. This is the recommended treatment. Medications, I can tell you there are no medications recommended for pediatric, no current level medications. The individual surgeries is rarely recommended. So American Society guidelines have recommended diet, exercise, and weight loss. Yes, hypocaloric diet, like reduction of 500 calories of 1,000 calories and moderate intensity active exercise will help to improve NAFLD and improve liver enzyme histology. EASL, that is European Society, has recommended Mediterranean diet, I think, which is difficult to follow in India. So Indian Society, what we have seen that any hypocaloric diet, whether it be low carb, low fat, low sugar, any diet which focus on weight loss may be considered. Mediterranean diet may offer advantages. However, as said, it is difficult to follow in India. So Mediterranean diet consists of seafood, olive oil, nuts, cinnamon to add cinnamon and all. It's very difficult to follow in India, but so we have not recommended it. And the most important thing, processed food, junk food, and sugar sweetened beverages should be avoided. So this, in fact, the first recommendation was taken out from this study. This in fact was my thesis when I was doing my DM. So what we did, we had taken two groups. One group we had given this diet, a Indo-Mediterranean diet. So basically, an Indianized version of Mediterranean diet, in which we told the parents to take to use olive oil or sesame oil. We told the parents to have some nuts. We told the parents to use cinnamon to decrease dairy content, to decrease red meat. This was with the help of the dietitian. So this is a group on Indo-Mediterranean diet, and this was a group on calorie restricted diet. That is a diet where we reduce the calories to 500 calories of the actual calories required for the child. And what we saw, you can see in both diets, after 6 months, there was decrease in the weight, there was decrease in the BMI, even AST/ALT had decreased. Also, you can see the CAP values, the steatosis and fibrosis value are decreased. Similarly, in this group, that is low calorie diet, here also we can see AST/ALT are decreased. So ultimately, we thought that any diet given to a kid helps in the improvement of NAFLD. So these are in fact, the photos from my study. You can see after 6 months, the kids, with the massive improvement. This was the highest. This was a 16-year-old with 127 kg was the weight, and this is after 6 months he was 101 kg, and I can tell you the all the enzymes has become normal. So these are some of the photos. So this, according to the guidelines, these are the drugs which has been shown in some of the studies. However, none has been recommended. So I'm not going to in details, but however, I use sometimes vitamin E and metformins for some of my patients. But as I said, only in some of our patients and looking after the profile of the patient. Surgical is not usually done. There are only two recommendations. Any child more than 12 years who had failure of appropriate trial of intense lifestyle modification. So if you have given a lifestyle modification, you have done pharmacotherapy for at least 6 months and it is failed, then you can try surgery, especially in class 2 obesity, BMI 35 to 40, and any of the significant comorbidities like diabetes, OSA, GRD, or dyslipidemia, or BMI more than 40. It is very rare. I have not done for any of my child with NAFLD. So, as I said, I'll just touch upon the theoretical. I think theory is quite boring for everyone. So now we'll go to the practical purposes. So I will discuss few cases how a fatty liver can present in your clinic. So going on to the cases, first child, I have a 4-year-old boy with a normal birth history who came at 4 years with complaints of constipations and abdomen since 1 year. And this is a very common scenario which we face in our OPD practice with absolutely normal past history, family history, development history. The parents had abdominal pain. So every parent go and does a USG because so they found out that he had grade 1 fatty liver. and rest were normal. So they came to me when I saw this child. He was obese. BMI was more than 98%. There was no ictus pallor. Liver was 3 centimeter below right coastal margin. Was soft. No spleen, no kidneys. Rest examination was normal. The baseline investigations, you can see CBC was normal. Bilirubin was normal. There was transaminitis, ASTLT 180-210. Rest investigation was normal. They had also shown outside and was evaluated for viral enzymes because sometimes this, especially HCV and HBG, can be asymptomatic. However, all these viral markers were negative. So, how will you interpret this report? So, is it actually NAFLD? So, I don't want to, because of time constraints, I will go ahead. So, just a slide. This are some of the red. I think everyone should take a photo of this. This is just some of the red flag signs. So, if in your clinic, starting from 0 years to 18 years, if any of the child have this features and abnormal liver labs and any of these features, you have to investigate him for metabolic liver disease. Like any child with consanguinity, abortions, any child with a history of SIDS, sudden infant death syndrome, any child of recurrence of ALF, recurrence of transaminitis during catabolic stress, recurrent vomiting, diarrhea, failure to thrive, multisystemic involvement like CNS involvement, seizures, hypotonia, CVS involvement, jaundice, hepatosplenomegaly, any of these features, you have to investigate for metabolic liver disease. Our child first was the previous case was a 4-year-old and he had a hepatomegaly. And what I said, you remember to whom to screen any child with less than 8 years with a hepatomegaly or with a fatty liver, you have to rule out metabolic causes. So I did first line metabolic workup. So usually first line metabolic workup consists of the common etiologies you see like tyrosiniemias, like galactosemia, like glycogen storage disorders. So I did the first line metabolic workup like AFP, urine NGRS is for galactosemias, lipid profile is for GSDs, lactate is for GSDs. So all his first line metabolic was normal. So now I have a child with transaminitis, with fatty liver, with first line of metabolic workup normal. So whenever the first line is normal, you have to go ahead with the second line because as I told you, less than 8 years, you have to rule out, definitely have to rule out some other cause. So I did a biopsy and what I saw, so definitely the child had steatosis and he had some fibrosis, but this is a classical pattern. This is a textbook picture of plant cell-like appearance. And usually this is normally seen in glycogen storage disease. And we did a staining here. We was PAS sensitive and diaster sensitive. So we knew this is a case of glycogen storage disease. But to prove which type, I said a genetic workup and he was found out to have JSD type 6. So GS is as Dr. Ingle madam has shown a case. GS are beautiful disorders except for GS type 1 and type 4. Type 4 are such children usually can come at 1 year, 2 year of age with cirrhosis and they usually require an early transplant. Even type 1 are very notorious to diagnose and very notorious to treat. Rest all GSDs are very beautifully managed with proper medical management. Once you start uncook cornstarch and once you manage them medically, within 2-3 months, all their transaminitis, liver enzymes become normal. Even after 2-3 years, their organomegaly becomes normal. The growth becomes normal. So this is an important case. Sometimes less than 8 years, you can miss a GSD. Going on to the second case, here now I have a older child, a 9-year-old female, came to me with normal birth history, came with complaints of abdominal pain since 1 year, and the growth was preserved. This is also common scenario. Family history, development history, past history was normal. This also, they had done a USG outside, which showed grade 2 fatty liver. There was no splenomegaly, no ascites. He, on clinically, the vitals were normal. The child was obese, 90 BMI of 95%. She had this type of features on her neck. This is a typically seen acanthosis nigricans. And there was no icterus pallor. Liver was 2 centimeters soft and breast examination was normal. This are her labs. In September, August, and in July, September, and August, you can see there was persistent transaminitis. There was a elevation of GGT. Rest all investigations were normal. As I mentioned, USG just showed grade 2 fatty liver. There was no splenomegaly, no ascites. She was investigated outside. Her liver enzymes, viral markers was done, which were normal. Even sepsis workup was done, which was not necessary, but it was done, it was normal. So how will you interpret this child? So if you'll see, definitely she's a case of NAFLD. Definitely, because you saw that the classical acanthosis nigricans on her neck. So she was given a trial of lifestyle modification, a proper diet, a proper exercise, and in fact, she had lost 5 kg. But when she was referred to me, she had referred her in November. After 2-3 months, after losing 5 kg, there was not much difference. You can see still there was persistent transaminitis. So when she was referred to me, I thought, yes, definitely this is NAFLD, but she's not improving. So whether I'm missing something. So I just did a CLD workup, that is a chronic liver disease workup. The most common two etiologies in India are autoimmune hepatitis and Wilson disease. I just did a workup because sometimes autoimmune hepatitis and chronic liver disease, or Wilson disease, can be asymptomatic and just can present with transaminitis. So I just did this rule out, and it was normal. There was no evidence of autoimmune hepatitis, no evidence of Wilson's. So in this case, I went back and I thought whether I'm missing something. So as all our legendary teachers like Ambedkar sir, like NC Joshi sir or Umali ma'am always tell us, you should always go ahead and ask the patient his story, that is history. So on probing, I got to know that this child was on some Adleaf syrup, and the contents of this are some this herbs. I even can't pronounce this. And the child was also on Leave 52. This is a very common medication which is used in practice. Like even quacks use it a lot. But these are the actual contents. I think most of must have not seen, but this is the actual contents of Leave 52. And there's a website called Liver Talks in which you can see which herbs are hypertoxic. And I can tell you out of this, 5 herbs are hypertoxic. So so I thought this might be a case of drug-induced liver injury. But however, I did a biopsy, and on biopsy, there were features of, in fact, cholestasis, plasma cells, and these are classical features of DILI, that is drug-induced liver injury. And you can see when I stopped this drug, within next 4 months, the transaminitis slowly became normal, and within 4 months, the liver enzymes became normal. So actually, this was a case of NAFLD. However, there was a component of drug-induced liver injury. So this is also a beautiful case which you should always ask history of alternative medicines like Ayurvedic, homeopathic medicines to see if we are missing something. Going on to my last case, I'll just finish with the next 5 minutes. I'm sorry to take your time. So the third case, 11-year male child, absolutely normal birth history, came at 11 years with complaints of abdominal pain and constipation since 2 years. This is also a very common scenario, with absolutely normal past history, family history, development history. He also had a grade 1 fatty liver with no splenomegaly, no ascites. And here you can see his weight and height are normal, but weight is on the lower side. There was pallor, no icterus, no chronic liver disease stigmata. Per abdomen, there was liver 2 centimeter below right costal margin, 2 centimeter was episternum. It was 4. No spleen, no ascites. Rest examination was normal. He was investigated outside, and there was pallor. Bilirubin was normal. There was mild transaminitis, and albumin was low. Also, he was investigated outside for viral markers, all multiple viral markers. Even EBV was done, which was normal. So how will you interpret? So if you look at this case, there are few red flag signs. One of the red flag sign first was on the growth parameter, height is on the lower side, not absolute normal, but the Z scores are minus 1.89 Z scores. First. Second, there's pallor. So, and you will see there were no features typical of iron deficiency anemia. Third, liver was there and left lobe was palpable but firm. So this shows that there's something, a different element. And also in the labs, you will see the albumin component is low. Usually when albumin is a synthetic function of the liver, when the albumin is low, it shows there's some damage to the liver and a long-standing damage. So thinking of this, in fact, he was given outside advice for giving oral laxative, iron, and exercise and weight loss. And after this, still there was a transplant. So when he came to me, I just investigated him for, as I said, two common DDs, autoimmune hepatitis and Wilson. And he was found out to have Wilson disease. This is a typical cell plasmin 4 KF ring was positive. And this was a case of Wilson disease. And you can see after starting chelation, within 2 months, his AST LT became normal. So this is also a different case, to see that Wilson's can sometimes come as asymptomatic just on transaminitis. The red flag signs are growth failure and the firmness of the CLD features. So this is a list. This is the exhaustive list of secondary cause of fatty liver. Sometimes all this disease can just come as fatty liver. Out of this GSD, which we saw, cystic fibrosis is another common. Tyrosine Wilson's. These are very rare. HCV. Out of the gastrointestinal, yes, celiac and IBD are common. This can come just with fatty liver. Celiac can just with fatty liver, growth failure, and loose stools. Endocrine is also rare. Take home messages. Suspect NAFLD in every overweight obese child, especially with family history of metabolic syndrome. Lifestyle modifications are the key. You have to make sure this child follows some diet. You have to tell them to do exercise. This is the most important thing. Children less than 80 years with fatty liver should be investigated for secondary cause. And always watch for red flag signs, which I've mentioned for metabolic liver disease. Any child with red flag from 0 to 18 years has to be looked out for any metabolic liver disease. This is my personal number. You can personally contact me for any questions or any doubts. And I'll just like to announce that I usually sit in Virar on first and third week Saturday in Ankur Hospital. And from May, I will be starting my OPD in Vasai. I'm happy to take questions now. And sorry to take your time and thank you.
Wonderful presentation, Aniket. Thank you so much.
Lovely. Very nice, Aniket.
Thank you, ma'am.
Only I got baffled by all the NAFLD and SAFLD.
I know, ma'am. So this is the reason I just put theory a little. I try to showcase it because these are the common cases. Sometimes we missed it.
Yeah. Yes, yes. Only we are not familiar with it all.
Yeah, I'm sorry. I know. Yeah.
Yeah. No problem at all. Wonderful.
There
Wonderful
are so
session
many, I
overall.
think, questions, but still we are in the time constraint. So I want to thank you so much, Dr. Nilesh Palwankar. We would like to learn more from you for hypernatremia part 2. Thank you, Dr. Madhavi Ingre, madam, Dr. Alka Jadhav, madam, who shared with us an interesting case. Thank you. Thank you, Dr. Prasida and Dr. Preeti Mupkar. Madam, we will use the PCR investigation in more insightful way now. And thank you, Dr. Aniket Deshmukh, sir, for sharing the preventive aspects of NASH, now called as
MSLD.
LD.
LD.
Yeah.
Metabolic
Thank
acidic
you,
liver disease.
Dr. Tomia, for moderating the session. And thank you all our august audience
you.
for patient listening. Thank you so much. Dr. Aniket, we have many questions, and since you have shared your number, we can ask you
Connect.
directly
Yeah, ma'am. Directly.
or
Yeah.
refer the patient to you now.
Thank you, ma'am.
Thank you so
Yes.
much.
Well done, Dr.
Thank you, ma'am.
Soumya. You did well.
Thank you.
All speakers were wonderful, Soumya. Very
Thank
nice,
you, ma'am.
Jayashree.
Thank you, Archana madam, and thank you, Anjali Gokarna madam.
It was an excellent session. Top.
Excellent session.
Excellent.
Thank you.
Thank you, ma'am. Now we can conclude
Yes.
the